1, ymlaen.
Bore da a croeso I gyfarfod bwrdd iechyd Prifysgol Cymtaf Morgannwg. Hoffwn I estyn croeso cynnes I bawb sy'n gwylio heddiw. Good morning and welcome to the Cymtaf Morgannwg University Health Board meeting. I would like to extend a warm welcome to all who may be observing the meeting today. We are broadcasting today meeting at the board live, providing the opportunity for anyone with internet access in real time using a link that was shared by various channels prior to the meeting. I would like to therefore extend a welcome to all who may be observing the meeting today. In relation to today's proceedings, I'd like to note the following. For those observing, I just wanted to advise that we may not always be looking at the camera, as we are also referring to our board meeting papers throughout the meeting. We will also be taking a very short break at an appropriate time during the meeting after about an hour at around 11 o'clock and possibly again at 12 o'clock, depending on timings. For board members, as you will be aware, questions on the consent agenda have been sought in advance of the meeting. I would like to advise the board that Anne Morris has been successfully appointed as one of our new associate independent board members. Whilst Anne is unable to join the meeting today, I'd like to extend a warm welcome to Anne, and I look forward to seeing Anne at future meetings of the board. I would like to welcome Mandy Welsh, heart failure nurse specialist, to the meeting. Mandy is here to present the patient story item as agenda item 2.1. I'd like to welcome Gethin Hughes, Chief Operating Officer, to his first meeting of the board. Gethin commenced post in April 2022. I'd like to welcome Daniel Price to the meeting. Daniel has been appointed into the role of Chief Officer at Cymtaf Morgannwg Community Health Council. I'd also like to extend my thanks to Kathy Moss, the previous chair of CTM CHC, for all the support she has provided to the board previously. I wish Kathy all the best in her retirement. I would like to welcome Claire Nelson, Assistant Director of Planning, who is attending the meeting on behalf of Linda Prosser, who has tendered her apologies. I would also like to welcome Wendy Penryn-Jones, Head of Board Business, who is representing Georgina Glattley, who has tendered her apologies for today's meeting. To give you advance notice, I do at the end of each board meeting, I will be asking colleagues how you think we have done once we have completed today's agenda. There are a number of questions set out at the bottom of today's agenda that are there to act as a prompt for us all to consider as we work through the items for discussion today. I encourage all members to keep this in mind and offer reflections and suggestions at the end of the meeting to ensure we are working effectively as a board. All chairs of committees have also adopted the same approach after each committee meeting of the board. Now to item 1.2, apologies for absence are received by Geraint Hopkins, independent member, Lauren Edwards, Executive Director of Therapies and Health Science, Linda Prosser, Executive Director of Strategy and Transformation, and Georgina Gallifley, Director of Corporate Governance. We could then go on to declarations of interest. We've not been notified of any additional declarations of interest prior to this meeting. On to item 2.1, which is the patient's story. I'm pleased to invite Mandy Welsh, heart failure nurse specialist, to present today's patient story. Mandy.
Bore da, a diolch yn fawr iawn am y gwahoddiad bore yma. Thank you very much for the kind invite to present my patient's story, and in particular his journey, his heart failure journey through our service, and indeed him using our heart failure self-monitoring app, which was developed and piloted in the Royal Glamorgan Hospital, the first of its kind in the UK, and an innovation we are incredibly proud of here. So before he's opted to video his presentation, very wise, and so I just wanted to provide some background information and context about the prevalence of heart failure and it's burden both on the patient and on the NHS. Okay, why can't I move my slide along? Thank you. So very basically, what is heart failure? It's the inability of the heart to pump effectively. And this is due to the heart being unable to squeeze and relax in each heartbeat, due to muscle damage. And it is the end point of almost all cardiovascular disease. We have seen an influx of heart failure, new incidences of heart failure due to COVID. This is because of the myocarditis that it causes, the scarring in the ventricle, and there's definitely been a huge number of referrals because of COVID. But there's many other causes of heart failure. Alcohol, drinking too much alcohol, we see that a lot in the Welsh Valleys. It's caused by chemotherapy, post-pregnancy you can have heart failure, so there are many causes. And it is a condition that is chronic and often gets worse. Next slide, please. So there are over 1 million people living with heart failure in the UK. It is the only cardiovascular disease which is increasing in prevalence. This is due to the fantastic work now done by our intervention cardiologists. When you have a heart attack, you're basically taken to the lab. 24 hours a day now we're open, and people are surviving longer after having their heart attacks. There are 40,000 people that we know of living in Wales with heart failure, and over 4,000 in Cwmtaf Morgannwg. Acute heart failure accounts for over 5% of all hospital admissions, which is a huge burden for the NHS. And this statistic is not a nice one. Over 30% of patients diagnosed with heart failure will die within 1 year of diagnosis. This is higher than most cancers. The readmission rate is high, and I'll explain a little bit later why that is. And patients describe an extremely poor quality of life, and indeed a high incidence of anxiety and depression within this patient group. Next slide, please. So these are the symptoms that the patients will experience when they have heart failure: shortness of breath. This, they can't even walk up a flight of stairs without having to stop and catch their breath. This is normally the first sign for patients. Swelling of their legs and feet and abdominal distension. And quite often my patients come into clinic, they can't even put shoes on, they've had to cut slippers, and this is really embarrassing for them. They don't want to go to social events because people are looking at their ankles. A chronic lack of energy. They wake up and they have to go to bed within an hour, so they're unable to hold down a full-time job. Difficulty sleeping at night due to breathing problems. Patients describe this as being incredibly frightening. So we have many octogenarians with heart failure who live alone, and this is why our readmission rates are so high, because they feel as though they're drowning in their own fluid at night and having to almost sleep upright. And because of their fear, they end up phoning 999 and coming in to A&E to offload some of that fluid. And confusion, impaired memory, cough, a chronic cough that they're trying to clear their lungs of this fluid constantly. Next slide, please. So the treatment for heart failure, our job as a heart failure nurse is to keep our patients away from the revolving door of admissions that these patients have. So we see our patients for an hour on new diagnosis, and to give them the education about their condition, and to really point out to them there's the things they can do to promote better outcomes for themselves. Living a healthier lifestyle, stopping smoking, cutting back on alcohol, keeping your weight under control. And we particularly encourage self-awareness of deterioration of their symptoms. We discharge our patients fairly quickly in order to see patients quickly, new diagnosis, but we have an open door access to our patients. They don't need to go through their GP. They can contact us if they find the symptom burden beginning to progress. We should be their first port of call, and we can significantly reduce readmission rates by seeing them in their own homes to give them high dose diuretics to get rid of their fluid. Then we provide onward referral for pacemakers. So now we have excellent devices that we can treat heart failure. Perhaps they need stents in Cardiff. We refer them for revascularization. We have an excellent palliative care service now for our heart failure patients, and we're currently recruiting for that. We've been doing the pilot for 12 months, and the outcomes have been fantastic. It allows patients to choose their place of death, and rather than dying in hospital, which is what they don't want, we're able to provide that care now in their homes. And then cardiac rehabilitation. We know outcomes for patients are much better if they attend cardiac rehabilitation with heart failure. We've not been funded for this, but thankfully now to our value-based healthcare, we are about to embark on a gold standard heart failure cardiac rehabilitation programme, the first of its kind in Wales. Again, extremely proud of that. And last but certainly not least, we are incredibly lucky in cardiology that we have gold standard randomised controlled trials involving thousands of patients worldwide. So we know the evidence base is robust for our heart failure medications. Our patients need to be on 4 different types of heart failure medications, and that's our job as nurse prescribers to get them onto these medications as quickly and as safely as we can. The quicker they're on the 4 tablets, the better their outcomes. They have reduced mortality, reduced readmission rates, and an increased quality of life. But the problem with the problem with these medications is just not one tablet and then another one. You titrate according to their renal function, their blood pressure, their heart rate, and their symptoms. They can cause a lot of dizziness, and actually we can make them feel worse before they feel better, and that's really important that we tell them that in the education, because if we expect our patients to be compliant with medications and expensive medications, then they need to know the side effects and that they will eventually feel better. So you can imagine our dilemma when the first wave of COVID hit us. We had to stop all face-to-face activity. Our patients were older, frailer, vulnerable, had many comorbidities, so we wanted to keep them as safe as we could, so didn't want to bring them into hospital to see them. We had staff redeployment covering the COVID wards, and we had long-term COVID within our team, and patients' fear of seeing anybody medical, as you can imagine. So we needed to look at ways to get these medications on board. And we were approached by Life Sciences Cymru and a company called Humour. They were actually looking for somebody to do a COVID virtual ward, which I didn't want to do, but I thought, well, hang on, if you can monitor patients at home with COVID, their blood pressure, heart rate, oxygen levels, etc., then why couldn't we do this with heart failure? Next slide, please. So we started the very long process. So I approached 2 cardiologists within the Royal Glamorgan and asked, I said, I'll take the lead and I lead with this, but could we please consider having an app for patients to monitor at home? So this is what we did. So patients capture relevant clinical detail according to our agreed management plan. In the beginning, it was a daily basis. So they were provided their own blood pressure monitor, saturations monitor, weighing scales, and on the app they had a symptom burden monitor. And they needed to have a smartphone and they needed to consent to this, of course. And then the app then connects to a web-based platform which the clinician looks at every morning, Monday to Friday, and it gives you a really clear trend of what your blood pressure, your patient's blood pressure, heart rate and symptoms are doing, and we're able then to prescribe our medications just based on looking at this data and then phoning the patient. The patients are provided with blood forms through the post, which they go to their local hospital to arrange. We don't involve the GPs with this because it works well. They don't have to make an appointment and they can go at their leisure. And then any changes to the patient's care condition are documented in the medical notes as you would do per phone call. Next slide, please. And so these are the outcomes that we've measured. We've definitely avoided admissions because you can put up to a stone in weight with heart failure in about 4 or 5 days. And obviously this is evident when it comes up on our dashboard that the weight has shot up. The symptoms will reflect that. We're able to go into the patient's home and give them high dose diuretics to avoid admission. The medication optimization time has reduced by 74%. That's huge. And we're managing to get our patients on all 4 pillars of heart failure medicines in 28 days. Again, the only hospital in Wales doing that. It has facilitated early discharge, and from our coronary care units, especially during COVID, when patients were petrified of contracting COVID, we were able to keep a close eye on everything once they were home. It has encouraged medical compliance, as you can imagine, as they're having to input their own data. It's giving them a sense of empowerment. They can see that the medications are bringing their blood pressure down, their heart rate down, so it's really encouraging that compliance. And a reduction in face-to-face clinics and footfall in our hospitals. So that was a very quick whistle stop, because the most important part of this is listening to Mr. David Watkins from Treherbert, who is my patient, is going to present on his journey, and I'm happy to take questions at the end of Mr. Watkins's presentation. Thank you.
Thank you, Mandy, and welcome, Mr. Watkins.
My name's David Watkins. I'm from Treherbert at the top of the Rhondda Valley. My heart condition first started about 20 years ago. I found out that I needed a triple bypass. Then 20 years later, something else must have worn out, and I found myself filling up with water. The impact on my life was awful when I first had it, because I couldn't do things. I live in a 3-story house. It was difficult to answer the door. It was difficult to get up. You felt as if you didn't want to do anything. I knew that I had to do something about, or hopefully someone would help me do something about this. When my heart failure nurse first introduced me to the Humour app, I was quite excited, to be honest, because you take your records every day and you write down your heart rate, how you feel, your blood pressure, etc., etc. And I really enjoyed using that app every day, because when you had a good reading, it affects you because you think, oh, well, you know, you feel good about it. When I was using the Humour app, I never felt isolated from my heart failure nurse, you know, because the thing was being seen every day was kind of a confirmation that somebody was monitoring my health and my condition. So that was a great thing. Right now, as he searches for wood to touch, I'm feeling great. I'm almost, because I was talking to my wife yesterday, and I said, I don't really want to say this, but I just feel more normal than when I was normal. One of the biggest upsets, personal upsets for me with my heart problems, was the fact that I couldn't play drums. After I met my heart failure nurse and was on the medication that she prescribed for me, I found a vast improvement of that, and I found that I could actually go and do something that I've done and loved all my life. Now, that was a massive thing for my my soul, my well-being, you know, and I can I can never thank her, actually. I just can't. I would absolutely recommend using the Humour app for this condition, without question. I'm always skeptical of certain things, you know, and I might have been at this one until I started using it and seeing the value of it. And of course, when it went, it was like losing an old friend, you know, because I'd been using that day by day. I think I would like to have kept the app, because when you have a condition like this, it's all about confidence. It's all about confidence to work and live. It's simple as that. That's the simplest way you can put it. you know, you just want to be normal as you can, even if you were not as normal as you was yesterday. And the Humour app, monitoring that gave me that confidence, as I said earlier, to just get up and do what I think I should do for that day. Live, really.
He was wonderful. Thank you, Mr. Watkins.
Well, I have to say, Mandy, thank you for an excellent presentation on the work that's been undertaken in heart failure within the Health Board. That was pretty impressive on what you've shared with us today. And a big thank you to Mr. David Watkins in sharing his experience with us too. I'll just ask if there's any comments or questions any of our colleagues would like to make to Mandy, please. Stuart?
Thank you, Emrys. I think there are other colleagues who are in before me, but I will take this opportunity if that's okay. Yeah, no, fantastic work, Mandy, and it's been a pleasure actually getting to know you over the last couple of months and seeing how this work is evolving. And I guess what it does really lend itself to is how we create further opportunities in the future and think about other ways, other specialities in which we can provide some of this self-monitoring functionality. It's clearly part of our longer term plans in terms of how we provide our services. So this is just a great first example of how we really can change the way people interact with our services going forward. So well done.
Diolch, thank you.
I'm sorry, I can see I'm going. Can I call in Kelechi then, please?
Thank you, Chair, and thank you, Mandy. I thought that was an excellent presentation, excellent description of the really important job that you guys do with these patients, and some of the work that we've been doing around population health suggests that, and you may be able to recognize this because you did hint at it, 95% of our patients who have congestive heart failure have at least one other long-term condition. So in your management of these patients, I'm just interested in your experience of helping them manage their multiple morbidities, given that your focus is perhaps on the congestive heart failure itself. How are you managing to help them interact and manage other conditions that they are very likely to have? What's your experience of that? Just interested in, because of the preponderance, if you like, of multiple morbidity in our communities.
Absolutely, and a recent survey showed that our patients have at least 7 comorbidities and for heart failure patients. We do link a lot, we have a lot of email MDTs with our diabetologists. The incidence of heart failure is incredibly high with diabetes, and there's new medication now that treats both. So we have recently started our MDTs with diabetologists. We have close links with all of our clinical nurse specialists in respiratory, diabetes, asthma, and we have strong links with primary care. And we do a lot of educational sessions so that we can treat these patients together. I mean, unfortunately, the app only concentrates on heart failure, and as Stuart alluded to earlier, it's important to have, when we're looking at buying into apps in the future, that there's lots of other comorbidities in one app, rather than having standalone diabetes, respiratory, COPD, etc., so that you have one that kind of fits all.
Absolutely, thank you. That's really helpful. Thank you, Mandy.
Thank you.
Paul?
Thank you, Chair. Thank you, Mandy. That was really great, and I've had the opportunity to have chats with Mandy a couple of times about this, and a couple of people in the sidebar have mentioned, this. If you look at where we're going as an organisation, and as Kelechi just highlighted, the prevalence of chronic disease being one of the biggest challenges we face as a health board, we have to find different ways of managing our population, and this is a really good example of how we can provide a more efficient way of caring for our patients outside of a hospital setting, which is where most people want to experience most of their lives, not in a hospital. But I think what was really telling from the patient's feedback was it isn't just about the clinical opportunities and efficiencies. It's most importantly, it's about the patient feeling normal and feeling that they're able to live their life as normally as possible despite having a chronic illness. So I think, you know, this has got to be a fundamental strand of our strategy moving forward, about particularly in the medical specialties, about long-term conditions management. And Stuart and I have been having a bit of a chat, because as Mandy highlighted, this was a pilot project that was funded through the Life Sciences Hub with Humour, who are an external organisation. But one of the things that Stuart and I have been discussing is how we might want to look at a solution that we would adopt across a number of specialties, because as Mandy said, we don't want to have patients who've got 5 or 6 long-term conditions having a separate app for every single condition that they're dealing with, because it slightly defeats the purpose of what we're trying to achieve. So I think there's probably something here we need to think about in terms of how we procure a solution that may be applicable across a wide range of specialties, and that we can start to roll it out into other areas. But I'd also just highlight, you know, Mandy has championed this really actively within the organisation and indeed across Wales. And the Life Sciences Hub have been really supportive, and so I just wanted to thank Mandy also for her personal resilience at championing this, because I know she's had to get a lot of people on board and convince clinical colleagues this is a good thing to be doing. And I think now the evidence is showing, hopefully, that will mean the rollout will be a lot more easier into other areas within cardiology and beyond. So thank you again, Mandy.
Thank you, Paul.
If I could invite Ian in, please.
Yeah, thanks, Emrys, and thanks, Mandy. I think we often talk at board meetings of some of the reasons why we might want to adopt digital technologies and in terms of taking things forward. And I think this is a really good example of that. And thank you for showing us this project. I think it's a really good story. And as I've said, I think it could be applied in other areas as well. But yeah, so really good example. I do need to declare an interest here, however, which I should have done at the beginning. I didn't realise you were doing a presentation on this. I was actually advising Life Sciences Hub on taking the various different projects forward at the beginning of this process, and so this was one of them. So I must declare that interest.
Oh, thank you very much for that.
Good, thank you, Ian. If I could invite Greg in, please.
Yes, thanks very much, Chair. Mandy, awesome work. We've had, you know, some discussions about this, and I just wanted to highlight to the board, I'm going to embarrass you now, Mandy. Mandy won with her colleague Vicky the British Journal of Nursing Cardiovascular Nurse of the Year National Award just in March, isn't it, Mandy? So we're very, very lucky to have you as part of our team. So thanks very much, Mandy.
Oh, thank you, Greg. Thank you. I was honoured.
Well, I have to say, Mandy, it's quite an honour for us as well to hear that you won that award. So really well done. And I have to say, I can't see any more comments here, but I can say you've given us an excellent presentation on heart failure. You've also given us an excellent presentation around how you can introduce, technology into care as well. As Paul was saying about this is the way we're wanting to move things forward. So really excellent. And again, obviously, thank you to Mr. Watkins for sharing his experience today. Well done, Mandy, and keep up the good work. You're doing really well. Thank you.
Thank you.
Okay, if I could then go on to item 3, please, which is the consent agenda. And to ensure we focus on business critical activity and discussions, we continue to use the consent agenda for this meeting. I should like to inform all colleagues of a slight change in approach to receipt of highlight reports from board committees. These will now routinely be included on the consent agenda for formal noting and will be placed on the main agenda for discussion only when there are specific areas identified in the report for escalation to the board. I am assuming that everyone has read all the papers under the consent section. Are there any issues that anyone wishes to move from the consent agenda to the main agenda for discussion? No, therefore.
Emrys, sorry, Emrys, no, it's okay. It's not that I want to move something onto the agenda. It's just I just wanted to raise a point on one of the items, which was the hosting agreements paper. Just to say, I think we might need to do a little bit more work on that topic in light of some of the conversations that are going on at the moment around the NHS executive, because there are some implications potentially for the hosting arrangements for some of the organisations we work with. So I was going to propose, if it was okay, that I'm not saying we don't agree it, but I just was wanted to make the point that we might need to bring back some further conversations to the board at some point about any implications of that, those changes that are going on at a national level.
Okay, thank you for that, Paul. Do you know what the timescales are on that, Paul?
Not exactly, Emrys. It's still early days, but I think probably it's going to be something after the summer. In the autumn, we'll probably perhaps need to have a further conversation, because there are some implications for us as the host, particularly for NCCU, WISC, ESC and other things. And there is also a bit of, I think, clarity we need to make sure that we as a board have about our responsibilities, which have sort of come to light over the past few weeks in some conversations I've been having with NHS colleagues in Wales. So I'll pick it up with George when she's back, and we'll perhaps bring something back to the board later on in the year.
Okay, thank you, Paul. Noting Paul's comments then, if I therefore propose that all members present are happy to approve and note all items as requested, and then can I move on to agenda item 4, please? Are there any matters arising not considered on the action log that anybody would like to raise? No? If I could then move on to item 5, please, on integrated governance and insurance, and if I could invite Paul Mears, our Chief Exec, to present the report which members have been asked to note. Over to you, Paul.
Thank you, Emrys. Sorry, I was just getting my camera on. Yes, as you'll see in my report, a couple of updates on some strategic developments in the organisation. Obviously, first of all, just to congratulate Dom for being appointed substantively into the medical director post. It's really great now that we've got him in situ in that role, and as we've talked before, that now means we've got a fully substantive executive team for CTM, which is a really big step forward for our organisation, so really pleased about that. Also, just wanted to highlight to colleagues that we are working very closely at the moment with Cardiff and Vale and Anara and Bevan Health Boards to look at how we can develop our approach to services across the region in South East Wales. I've been having several conversations with the chief execs of those two organisations, and we've established a couple of weeks ago we had a joint executive team meeting to talk about areas where we may want to work in a more joined up way across the region, and we've agreed as 3 organisations that we're going to focus on developing services regionally around orthopaedics, ophthalmology and diagnostics, and our planning director colleagues are going to act as the sort of overseers of those programmes of work, and the plan is that we will also look to appoint somebody from within the 3 organisations to be effectively a lead programme manager of the programmes of work to make sure that we maintain momentum and developing how those services work across our patch. It is a big focus for the Minister, looking at how health boards work in a more collaborative way, so it's very much something that she supports, and I think it also recognises that we have, as every health board does, some real challenges in terms of particularly our elective recovery, and the answer to some of these challenges is not just working better within our own organisations, but looking at how we might work more collaboratively across organisations. So really positive step forward there, and some great opportunities for improving services with our colleagues in Cardiff and in our Bevan. Also just wanted to highlight that we've had some really positive visits from local authority leaders and council chief executives to our 3 emergency departments over the past couple of months. I think it's been really helpful for colleagues to come in and see the pressures and challenges that the hospitals are facing at the moment, and it's also led to some interesting conversations with colleagues in the councils about how we can work in a more joined up way together, particularly on the agenda around discharge. So that's been really positive development. And also in terms of engagement with our clinical community, really pleased to report that we had a very successful session a couple of weeks ago with where we invited our consultants to come together. And we had over 170 consultants joining us for a briefing session for an afternoon, where we gave them an update on some of the key developments in the organisation around digital, around the strategy work, around the financial challenges we're facing. And then we broke out into separate groups to talk about some of the challenges within specialties, but also the opportunities there are with the new strategy work, and also some of the changes to the operating model. Really positive feedback from the clinical community about that session. Lots of challenges rightly back as well about some of the things that are going on in the organisation, but what we're probably going to look to do now is to run those sessions probably a couple of times a year, so it gives senior medical staff the opportunity to come together to talk about issues that are common across the specialties. But yeah, I think it's a really good opportunity to get the views of our senior doctors into some of our current challenges. And finally, there's an item on the agenda later on about the operating model, so I won't go into that now, but just to say that process of consultation is currently underway, and we're getting quite a bit of feedback from staff, which is really helpful to help think through how the new operating model may evolve and needs to evolve as we look to an implementation in the summer. So that's all I wanted to say, Emrys, on my report, and thank you very much. If there's any questions, happy to take them.
Thank you, Paul. Are there any comments or questions for Paul, please? No, only just a comment from me, Paul. Just to support you in that the work that's going on with our local authority colleagues is very positive and certainly supporting the system working going forward. And I know it's always been quite challenging trying to develop integrated or combined services in the past, and this looks like we're going in the right direction to help move both our service models between ourselves and the local authority and support our strategic agenda as well. So well done in moving that forward. Okay then, if I could then go on to item 5.2, which is the board assurance framework. Can I invite Wendy Penryn-Jones to present the report which members have been asked to approve. Wendy.
Thank you, Chair. As colleagues will be aware, the board agreed to the new board assurance framework, or BAF for short, at the previous meeting of the board in March 2022. At that point, the board agreed to receive the BAF initially at each meeting, noting that there may be little change during the intervening period given the strategic focus of the framework. We've since worked on populating the BAF with timely data and assessed the principal risks, which are presented to you in the report today for assurance. As members will be aware, the Organisational Risk Register has been received at each meeting of the board over the past 18 months to enable members to gain confidence in both the effectiveness of our risk management and escalation processes. The BAF builds on this and relies on these robust risk management processes to inform the assurances set out within the report. Whilst the Organisational Risk Register is appended to the BAF today, with any updates summarised in paragraph 3.3, it is suggested that in future the board is presented with the BAF alone. This is on the basis that the risk register will continue to be scrutinised by board committees according to their assigned risks. So in terms of the recommendation then, we are seeking approval of the BAF report and also the proposal that the Organisational Risk Register need not necessarily accompany the BAF report to future meetings of the board. Thank you.
Thank you, Wendy. If I could, can I invite? I must be honest. I'm looking at the left. I've got the initials, but not the names. Oh, Caroline. Sorry, Caroline. Can I invite Caroline for comments, please?
Thank you, Chair. I just wanted to really make a comment to commend this paper and the board assurance framework, which I personally find is exceptionally helpful in giving us that assurance about how we're managing things. From my point of view, I don't think we do need the full risk register, because we do have assurance that that is scrutinised at each one of the committees. So it would seem a duplication to have it here. And I think this paper gives us that assurance. So I just wanted to support that really, and just commend the work that's been done on it, which I think is very, very helpful.
Thank you.
Thank you. Thank you, Karen. If I could then invite in Jane, please.
Thank you, Chair, and thank you, Wendy. It's really good to see the BAF in its full form, and I think it gives the board a lot of assurance. I'd also like to confirm that the risk register is considered in detail at individual committees, and I see no additional benefit to bringing the whole thing here as an appendix to the BAF. And clearly, if committees have particular concerns, they can use the escalation section of committee highlight reports to draw matters to the board's attention. I also welcome the new section of emerging risks. I think that shows that we now have escalation procedures actively working, and it gives the board early notice of emerging matters of concern, and the fact that the executives have their eyes on issues that are potentially arising. So it's really good to see that too. So thank you.
Thank you, Jane. If I could invite Patsy in, please.
Thank you, Chair, and thanks, Wendy. Yeah, I support everything that's been said about the board assurance framework. It's real progress and links our risks directly with the strategy, which is what we need to be doing at board. Couple of comments though, with regards to receiving the risk register. I agree we don't need to see that at each meeting for the reasons that have been articulated, but I do think it would be helpful for the board to receive it maybe once a year, even if that were in the consent agenda. I think it would be good governance for people to view the whole thing and to then be able to triangulate the risk register with the BAF, which is always a helpful thing to do. My point is not on the individual items, but on the BAF itself, and when you go into each individual item there, on many of the risks or many of the goals that have been itemised, the consequence of the risk changes, whereas the description of the risk remains the same. Now, I absolutely agree you change the likelihood of the risk occurring, but if the risk changes, then surely it's a different risk and the consequence is then different, and that happens on quite a few. I'll pick out finance in particular because I've warned Sally I'm going to do this. The current risk is 5, catastrophic, the highest risk possible, yet we know we have submitted a plan that's not in balance. Therefore, we know we're already in that position, yet the health board continues to provide excellent service to the population. It may not have the money for new and planned improvements, and that's to be worked through. So that there is huge risk there, but I'm not sure it being categorised as catastrophic it is the right thing for it. And there are a few things in there, but my main point is where the consequence of the risk changes without there being a change in the description of the risk, because the consequence remains the same. You just change the likelihood of that happening. Thanks.
Thank you for that, Patsy, and noting that point there as well, Wendy, for what we can do better on describing the risk assessments.
Thank you.
If I could then invite Ian in, please.
Yeah, thanks, Emrys, and thanks, Wendy, for presenting this. I'd like to sort of echo some of the comments that other people have said. Really, this document is getting better every time I see it, and it's giving us really good information, which is easily accessible. I particularly like now you put the hyperlinks in, which is even better. You can jump around the document from one place to the next fairly easily. So yeah, that's really good. Before the other people were speaking, I was a bit worried about the organisational risk register and the fact that the proposal is that we don't now see it at every meeting. And I accept what people are saying, it's monitored in the various subcommittees and so forth. But what I quite often still see, and I can see with this version of the organisational risk register, is that in the next review date.
Sorry, I don't know that one.
Sorry, I've got Alexa in my room. It just reacted. The next review dates are quite often not met in a number of the different risks. And I do worry that some of these risks will fall between the cracks, if you like, from one meeting to the next. I think maybe Patsy's recommendation, whereby we see it occasionally, would possibly plug that gap in terms of if we're not seeing it every meeting, at least we see it occasionally, and then with the regularity of the subcommittees and then with the board seeing it, we can then sort of keep track of that. So I would support what Patsy said. In terms of seeing this at an irregular basis.
Thank you.
Okay. I can't see any further comments here. Can I just confirm that we are prepared to approve the board assurance framework, but note in the comments that we will have an annual risk register presentation with the back to the board, and similarly that we continue obviously with the subcommittees that are monitoring and reviewing the risks. So are we all happy to approve? Yep, okay. Thank you. Can I then move on to the next item then, please, which is the Clinical Advisory Group Highlight Report.
Thank you, Chair.
And I'd like to invite Anna Lewis to present the report, which members have been asked to note. Welcome, Anna.
Hello, thank you, Chair, and hello, everyone. So the Clinical Advisory Group's met twice since our last board meeting. The first meeting in April, we discussed the proposed new operating model, which I believe is on the agenda later. Richard Morgan Evans joined us and presented the rationale, the timeline and draft model to clinicians, and we were joined by a lot of clinicians who don't normally join the Clinical Advisory Group, which shows how passionately clinicians feel about sort of hearing about the new model and getting involved. I would say that generally the attitude is a positive one, in that clinicians are certainly very positive about increased cross-site working, and definitely about the fairer access for all CTM patients to services across the health board. There was also a positive feeling from groups such as Therapies and Diagnostics that they're going to have in the proposed model their own care group, and they felt that would give them a stronger voice. There are anxieties that obviously any change does bring about anxieties, so I'll just mention a few of the main anxieties voiced by clinicians in CAG. There's a worry that by trying to standardise services that we offer across the health board, this will lead to a levelling down of services on certain sites where at present they are offering a higher level of service than is available on other sites. There's a concern that we'll lose the cohesiveness that's been built through the ILG models, so in particular between secondary care and primary and community. There's been a lot of close working and a lot of relationships have built up over the last few years, and so clinicians are worried that will be lost. There's obviously a strong need for digital integration before cross-site working can be considered, because at present the differences in the IT systems between Bridgend and the rest of the health board would make cross-site working almost impossible, and Stuart Morris was with us in that meeting and obviously acknowledged that as a necessity. There are some concerns about delays in transfer across sites for services. So, for example, with stroke at the moment, we have patients with stroke waiting on other sites for beds to become available. And the worry was that if we go to a model where certain services are hosted on certain sites, then those delays of transfer will continue to be a problem. And then the concern of a potential conflict of interest between scheduled and unscheduled care groups when you have 3 acute sites under winter pressures for beds, and how those conflicting interests would be balanced. So overall, I think clinicians welcome the opportunity to discuss it and the ongoing opportunities that are on offer to provide feedback during the consultation period. Moving on to the meeting we had last week in May, we had 2 really positive discussions. Actually, the first was around organ donation. So we were joined by David Jones, who's one of our own ITU consultants, but is also the South Wales Regional Clinical Lead for organ donation. So he talked to CAG about the complexities of organ donation, and I thought there were some really interesting points that came out of the conversation that I just wanted to bring up really. The first was rates of organ donation dropped off quite significantly during COVID and since COVID. And during COVID, that's very understandable because there were concerns about infection risk with organs donated from patients who died with COVID infection. But since I mean, I know COVID hasn't gone, but since sort of the peak of the pandemic and we're moving on, those levels remain a lot lower than they were before the pandemic. And the feeling or the thinking is that a lot of that is to do with end of life care and the number of visits that patients and that relatives have to patients who are in the end of life sort of stages within our hospitals. So patients who are dying in our intensive care units, because relatives aren't visiting as often as they would have done, they're not building up quite the same rapport as they had in the past. And then when they come and visit the intensive care unit and they're having sort of fewer conversations about how, you know, their relative isn't going to make it, then dropping into those fewer conversations, the concept of organ donation just feels too overwhelming for relatives of those patients. And that's led to a much higher refusal rate from relatives of potential donors. But interestingly, if you have a specialist nurse from the organ donation team present in those consultations, then the rate of refusal is much lower. And that just, I think, really nicely highlights the importance of a multi-professional team and having that whole team there really helps the patients to come to terms with those decisions. The team do a huge amount of work to look at any missed opportunity for organ donation, and our rate of organ donation is where we would expect it to be for a sort of hospital, for a health board with hospitals our size that aren't sort of major trauma centres. And we asked, what can we do to support the organ donation team? And there were a few things that came out of that. I think spreading the word, both amongst clinical staff and raising awareness, but also trying to tackle fears and misinformation in our communities is really important. And Lee Leesham offered during the meeting to take that up with Dave to look at how comms can support organ donation. He also mentioned being keen for something called a Gift of Life memorial, which is basically like a memorial that kind of celebrates organ donation, and at the moment with the refurbishments that are going on in PCH, I know he's really keen to work. There's some charitable funds, there's funds that come from the transplant National Transplant Organisation, and he's really keen that some sort of garden of reflection or gift of life kind of memorial be built into the plans there, and I know he's already working on that, but I just wanted to raise that at board. And then just lastly, we talked then about another form of software that can help us in the future, having just heard about Mandy's app for heart failure. We talked about the Attend Anywhere software, which is basically virtual consultation software. So you can, it's a little bit like having FaceTime, you can carry out a clinic consultation with a patient and you can see them on their phone. And it does really fit into the direction where we want to go as a health board. So it's it increases choice for patients, it's more convenient, it reduces transport costs, it reduces our carbon footprint, reduces cross-infection risks in our waiting rooms. So loads and loads of positives we heard. There are some barriers. So when you look at the use of it, it was used quite a lot during the pandemic when it was obviously sort of very necessary. And the use has dropped off, and clinicians were able to bring to that discussion the barriers that they're finding that mean that they're using it less at the moment in terms of its flexibility and things like technical support for patients. So Stuart Morris was with us during the discussion and outlined the fact that this probably needs to be quite a complex piece of work to look at that, which is an absolutely excellent sort of principle, but just how that can be more user friendly and integrated better into the systems that we have for outpatients, so that it's used more widely in the future. So that's it from me. If anyone has questions.
Thank you, Anna. If I could invite Dom in then, please.
No, first of all, thank you, Anna. I think it's just a nice summary of just how important CAG is, actually, and just how the topics of conversation are not sort of ones that we naturally have in this sort of board meeting, that to get a voice in of what is happening there. So thank you, Anna, and thank you to the team everyone who contributes towards CAG. Just pick up particular points on it, that the new model that you were talking about specifically there. I'm not going to go through every single point here, don't worry, and we can discuss lots of detail on it. But I think actually what it does, it really does highlight the fact that the clinical input is just essential in this. It's all very well coming up with a model, but unless you actually go out and listen to the clinicians, all these issues that are sort of a concern don't really necessarily get flagged up. So now we're listening to them, we can hear them. There's a really good process for getting that feedback, and that's feeding into it. And I think particularly the one, there's a lot on there that you mentioned, Anna, but the one I'm going to mention particularly is that primary secondary working, and that there has been a huge amount of progress, and that was where the ILG model really was working brilliantly, is it getting that in place, and we were just beginning to get some progress really there. But there's absolutely no intention for that to stop, that even though we're moving on the acute sites to that across the sites, there is still going to be within each site and their locality those meetings carrying on. So we almost have the ILG model running, and we have the acute site model running almost at the same time, because that was making such a difference. So that's not going to change, but it's a great process. This is how we need to be hearing about this, flagging up the big concerns. There is a good process for clinicians to feed in exactly as well. So as many ways as we can have for feedback is great. So thank you for that.
Thank you, Dom. If I could then invite in Gethin, please.
Thanks, Chair, and thanks, Anna. That was really helpful. I wanted to pick up the point you raised about concerns regarding service allocation and bed capacity, because I think that's a very real one for us, isn't it, as a health board? And there's workforce challenges about sustaining services on every site as well, and how we get some of those critical mass for some of those key clinical interventions as well. I'd say it'd be really helpful to engage with CAG, if I may. I'm just instigating a whole bed bed number modelling exercise to look at the number of beds we've got on each site and how they fit with the services that we're providing, and that we've got the capacity to deal with the pressure of winter as well. And so it'd be really useful to perhaps use CAG to test some of those items out and to look at what some of those options are going forward. But that would be really helpful, so thank you.
Thank you, Gavin. If I could invite Stuart in then, please.
Thank you, Chair, and thanks, Anna. I was going to make a specific point around Attend Anywhere, but before I do that, I just want to reaffirm Dom's points actually around the group and how useful it's been to me coming into the organisation to have such a broad range of clinical colleagues to engage with, and and understand some of the challenges that they do have around the digital agenda. On the Attend Anywhere, you absolutely raised the right points. I think. Notwithstanding some of the sort of digital technical training usability issues that we will need for both our staff and patients, I think it's really important to remember that when we implemented Attend Anywhere during the pandemic, it was very much about enabling a way of delivering services as opposed to really thinking through the whole service transformation and change piece. And if we think about face-to-face clinics and physical clinics, colleagues have a number of support mechanisms around them in terms of other healthcare professionals to facilitate some of the running of those clinics. And when you've not got those in a virtual world, I think that's one of the things that we really need to look at in terms of remapping the whole process. So really excited that we can't lose this incentive that we've now got and this drive forward. I do understand that there will be an element of people that will still want face-to-face, and that's both professionally and from a patient perspective. But actually, I think if we really do map a service improvement piece on this, I think we can flourish with it. So really encouraged and really looking forward to working with the team on it. Thank you.
Thank you, Stuart. If I could invite Paul in, please.
Thanks, Emrys. Yeah, just to re-emphasise really how important this group has been, I think, since we established it. And I know it's had some ups and downs, and we've gone around and thinking, have we got the right people? And then we've slightly altered it, and then we've tweaked it again. But I think that's natural when you're sort of setting something like this up. And I think, candidly, it's trying to also help clinical colleagues realise that we do want to have their voice, and that it is worthwhile coming along, because actually I think some of the descriptions of the conversations Anna's just given show that actually having clinical colleagues along to these sessions does give us a really rounded perspective of what's going on. Greg made a point, that this is what I wanted to just raise, that he's right, that we do need to make sure we get a good cross section of clinical staff. We do have some therapy colleagues in there. I think it's light on nursing. Part of that, I think, is the challenge of nurses, particularly on wards, being able to find time to come out and join the sessions. But I think we need to give some thought, perhaps Greg, we can have a chat with your senior nurse team a bit about how we might want to do that. And also remembering that it isn't just ward-based nursing. We've got community nurses, we've got health visitors, we've got mental health nurses, we've got all sorts of different people, and also non-registered staff as well. So I think as we start to move into the next phase of this group, I think it's a great opportunity to look at how we can bring on the other professions into it. And finally, I just wanted to say also, Emrys, that Anna is stepping down as chair of CAG, and I just wanted to thank Anna very much for taking this role on from something that was just a grain of an idea, which I had not long after starting at the organisation, to really getting it to where it is today. And I know she's done worked really hard to build the group and make it a valuable resource for our clinical colleagues. And I think she is handing over a group that is now pretty well established within the infrastructure of the organisation as a mechanism for clinicians to have their voice. So really just wanted to give Anna a very big pat on the back for getting us to the point we are now, and thank her for all her contributions so far.
Thank you, Paul. And just to say, from my perspective as well, Anna, thank you very much for the work that you've been doing on clinical advisory group. And I know that we've had some previous discussions about how it's been developing, and it's fair to say we've done a significant amount of work in progressing that agenda. So Thank you, and thank you for your input for today's meeting.
Well, thank you all, and you know, I think the principle of the fact that you're working so hard to improve, you know, clinical engagement genuinely, you know, feels like a really positive thing for us as a CAG. So we're grateful to the board for being so encouraging with it, really. So thank you.
Thank you. Okay, if I could go on to the next agenda item, please, which is 5.4, and it's the Nurse Staffing Levels Act report, and it's the annual assurance report. The exec lead, obviously, is Greg Dix, our Director of Nursing. He's invited Sharon O'Brien, the Assistant Director of Nursing, to present the report, which members have been asked to note. Welcome, Sharon.
Thank you. Thanks, Greg. Thank you, Chair. So taking into consideration that members have read the papers prior to the meeting, I think it's just important that I wanted to raise to the board's attention a few key points out of both of those papers. Before I start, I think it's really important to note that the pre-COVID pandemic, there were a total of 30 adult and surgical acute inpatient wards across our 3 district general hospitals. Currently, or at the time of the report, there were 34, plus 5 ward areas that were continuing to be repurposed into high care respiratory or critical care, and therefore they, at the moment, or at the time of the report, remained outside of the Section 25B wards. However, we know, and probably this week is ongoing, that wards continue to be repurposed to create the new clinical models as part of the resetting. Also on the 1st of October 2021, the second duty of the Act was extended into the paediatric inpatient wards, and there are 3 inpatient paediatric wards within CTM. So in looking at the papers, within the Act, there is a requirement to undertake a biannual acuity, and that's undertaken every year in January and June. So the first paper, which provides an update really following the January 2022 biannual acuity. And the key point that I wanted to highlight really here is that there has been a requirement for a temporary uplift in the nursing establishment on 5 of the 34 wards. And this has been based on the triangulated methodology, which is used to calculate the nursing establishment required to run a planned roster. So the nurse directors have signed off the workforce establishment templates as part of this process, but agreed it is as a temporary uplift. And I think that's really important because they're recognising that as their wards continue to be repurposed as part of the resetting post-COVID, that these establishments are variable and they may even change again before we finalise those clinical models on the wards. And outside of the biannual acuity, in particular during the pandemic, the Act requires that every time a ward is repurposed, that the staffing levels are reviewed and the Act's staffing establishment templates are completed as well. So that has been undertaken throughout the COVID pandemic, every time a ward has been repurposed and maintained on a health board wide spreadsheet to ensure that we're complying with the Act. I think they were the key things that I wanted to highlight in the January post-January acuity report. In relation to the annual assurance report, the May paper, there is a change in the annual report in that we have a requirement to report if there's been an impact on key care quality metrics due to not maintaining the nurse staffing levels. The incidents that need to be reported are the number of serious incidents and the number of complaints where failure to maintain the nurse staffing level was considered to have been a factor. So if you look at the data in the May annual assurance report, we can take a level of assurance that very little harm where the planned roster has not been met. However, we need to balance that, and that's taken into account that it may be due to underreporting. And as all staff do not use Datix as accurately as they could, and Datix has been quite complex to work around. But I think going forward, we know that with the new Once for Wales Datix reporting system, it does include a mandatory section that will prevent the incident reporter progressing through the incident form until they have answered the key question as to whether they believe that the staffing levels and not meeting the roster was a contributing factor to the event. So as that's rolled out, I think the data we will obtain as the year goes on for the next annual assurance report will probably be a lot more reflective. Within Wales, and as part of the Nursing Staff Act, we're also rolling out the Safe Care module into the Section 25B wards. Now within CTM, we plan to start that, I think, in June, and it's over an 18-month period. And this system is a live reporting system. So you will be able to capture staffing risks live, also relating to incidents, but it also asks you to demonstrate the mitigation and the rationale for the mitigation undertaken in relation to if the planned roster is not, there's less registered nurses on the plan roster or healthcare support workers. And if an incident occurs, what the staffing was at that time. And that is very much taking into account the professional judgment aspect of the Act. So it's asking the ward managers or the nurse in charge to input into that module with their professional judgment based on the patients that they have in the clinical areas at that time. I think in summary, it's been an incredibly challenging 2 years, with wards being repurposed sometimes more than once to meet the demands of the COVID pandemic. And, we know that wards are continuing to be repurposed, as I've alluded to earlier, as the clinical model changes and we start to reset. And I think, meeting staffing levels for the Section 25B wards has been very difficult at times due to the higher levels of sickness, due to COVID, but also due to the staffing needing to shield at home or can only work in green areas. The next biannual acuity is due in June, and I think this will be the first time in 2 years, really, where the majority of wards that were repurposed during the pandemic are returning either to their original speciality or being utilised to support a new clinical model. So I think realistically, we predict that in the second biannual acuity in June, it will probably be more reflective of a more stable acuity audit, really, since the pandemic started. And I'm not sure whether we'll be fully there then, if I'm honest, but I think it will be the first time in 2 years. But I also wanted to highlight that despite the challenges, there does continue to be success and achievements throughout the Health Board. Firstly, being the paediatric inpatient wards in the middle of the pandemic have successfully been incorporated into the Act from October 2021. Just as the pandemic was starting, we were just finishing our overseas registered nurse recruitment into the Health Board, and we recruited 216 overseas nurses. We still have 211 of those nurses working within Cwmtaf Morgannwg Health Board, and they're extremely settled, and a lot of them have gone on to receive promotions and take on additional speciality roles. And we have also recruited 188 nurses, student nurses, via the student streamlining process. And as part of your Wales Overseas Registered Nurse Recruitment Programme, there will be an additional 100 nurses recruited into CTM between April and November 2022, and the first cohort has arrived today. So I thought that was a nice end to celebrating success despite the challenges and meeting ensuring that we are meeting the important, the Nurse Staffing Act at very challenging times. Thank you. Happy to take questions.
Well, thank you, Sharon, for your very informed report on how the staffing issue has been managed. Can I invite Patsy in, please, who'd like to ask a question?
Thank you, Sharon. That was really informative, as the chair has just said. I've just got one question in relation to the January 22 acuity level audit, and that's at point 3 under key risks and matters for escalation to the board, which talks about the financial implications around the workforce changes being 724,434. I wonder, a couple of things really. Is that in the plan? What happens if we don't find that considerable amount of money, given that we are not in balance this year anyway? And what's the implication here?
I think, I'm not sure if Greg wants to add to anything. I'm going to say really, because I can comment on, you know, the establishments that we've provided during this time, during the COVID pandemic. I think the uplift that's required, my understanding is it wasn't in the plans, and I think that's because it's been a very dynamic process. So the ward may be rehab one time, and then all of a sudden it's turned into acute medical to meet the COVID demand. And I think what's been important in that is that the recognition of the need to increase the establishment, not 24/7, some of them are just overnight, and they're not always registered nurses, some have been healthcare support workers. But I think what the IRG nurse directors with the ward managers and the heads of nursing have done is recognised that actually this is something that we need to do as an immediate to support patient safety, to deliver the care that we need to, the standards we need to do, recognising though that that may not be the case in 3 months' time. So I think, and also not needing the workforce and agreeing that that's what's required, and the acuity audit is only a small part of the Nurse Staffing Act triangulation. So professional judgment comes into it, reviewing the key care metrics, but also the all reasonable steps. So actually we may not need a nurse on one of the wards tonight, and that ward may we need an additional healthcare. Actually, the heads of nursing, the senior nurses will balance that using all reasonable steps, taking into account the whole clinical picture of the acute hospital that day, and for the next 48 hours, how they can move staff around as well. So I think, you know, Greg, I don't know if you want to add anything to that on more of the IMTP and plans.
I think you've answered that very well, Sharon. The challenge we've got, Patsy, is the dynamism of the wards being repurposed, and I haven't signed off the establishments for those 5 wards that are detailed within the report, because I'm keen to ensure that the audit next month uses the triangulated methodology. You know, if it comes back and you know, there is a requirement to uplift, then we need to have those further discussions, but I haven't signed off those 5 establishments as yet, because I'm pretty sure the wards will continue to repurpose, as Sharon's just articulated.
Thanks, Greg. I note that you are not asking us to approve this, you're simply asking us to note it at this stage. So, thank you.
Okay, if I could invite Sally in, please.
So Greg's right, the situation over the last couple of years has been dynamic, but Patsy's also right to identify that we are incurring these costs. They are partly at this point reflected in month 1 as COVID costs, because the change in the ward structure has been prompted by COVID and needing to change how we deliver our services. There will be an expectation, having had a deep dive with Welsh Government colleagues yesterday, though, that those costs start to reduce. And so we do need to keep a careful eye on this, because there is no core funding available to meet this on an ongoing basis in our current plan.
Thank you for that, Sally. Just checking more comment. No, if I could just ask a question, is that noting all the work that you're doing in relation to obviously responding to patients' needs, dependencies, the skills that are required to respond to meet these needs, and obviously noting how you've had to be dynamic through COVID as well in responding to the issues. Does the obviously we've got different types of buildings across the piece, you know, across CTM. Does that come into effect around decision making? I was just thinking, you might have a very modern, single bedroomed building where you might have an old dated building with long corridors as an example. Does that inform some of the decision making on staffing levels as well?
Do you want me to start, Greg, and you come in? Within the Act, there are three metrics that we have to cover off to decide the staffing levels, RN versus healthcare support worker. And that is, the acuity is only one of them. So the nurses input on a daily basis for a month, they will start to do it continually with Safe Care, the acuity of each level of each patient on the ward. And they have guidance or Wales around what makes an acuity level 1 to 5. Secondly, then they use their professional judgment. And thirdly, they look at their key metrics, so pressure ulcers, meds errors, and falls, and the adult wards. And it is very much around using the ward manager autonomy with the senior nurses. And that professional judgment, I think, is key. So although they are balancing what they believe their staffing levels should be, taking into account your question around environment, if they felt that due to the environment and the level of level 5 patients, that they felt that they needed to ask for an increased staffing level, then they can do that within the professional judgment. And I think it's really important that the Act never wanted to remove that aspect from the final decision making around the ward establishments. Yeah. Greg, I don't know if you wanted to add to that.
If I may, thank you, Sharon and Chair. So it's a great question, Emrys, and there's different evidence which suggests whether single patient environment, single room environment should have an increase within core establishments. What we do across the Health Board is change our model of nursing care delivery. So, for example, within YCC, YCR, very stretched out wards with side rooms towards the end of the very long corridors. So then we changed the model of nursing in relation to the nursing stations being located in a different type of part of the ward as opposed to a general nursing station at the entrance. So we changed the model of care delivery within the professional judgment discussions. The environment of care, it features very highly. We have seen, and I presented some of this at the last board, some concerns with some falls with regards to some of our wards where we have increased single rooms. But what we try and do is ensure that those patients that are category level 5 with the greatest need are nursed closer to the nursing stations across our wards and environments. So it is a factor that we include within the professional judgment piece of the triangulated methodology approach.
Thank you. I can't see any other further questions or comments to be made, but one thing I can say is that the presentation gave us a good overview as to what's going on in relation to nurse staffing and how we are responding to needs, but also recognising the challenges that you've had to meet over this, particularly over the last 2 years. And it's really good news as well, and very positive to hear the number of nurses that have been attracted to come and work in the organisation as well. So well done to you, Sharon, and well done to Greg in respect to this. Can I just confirm before I go on to the next agenda item, does that cover 5.4 and 5.4.1? Okay, well, thank you again, Sharon, and thank you, Greg.
Thank you, Chair. Thank you.
Would it be useful to have a 5-minute break, colleagues? I can just check with you. Can I just make a suggestion that we break for 5 minutes and we come back and start again, or 7 minutes and start again at 11:30. Okay, so if I could just ask to we'll terminate the meeting temporarily and then come back at 11:30. Thank you. Can I confirm we're ready to start the next part of the meeting? Okay, the next agenda item is 6, delivering our purpose and strategic direction. And we're going to go through the integrated performance dashboard. Can I just invite Gethin Hewson to make a brief introduction of the integrated performance dashboard before inviting the exec colleagues to update us on different parts of the performance. Okay, over to you, Gethin.
Thanks, Chair, and it will be a brief overview, as I know colleagues will be taking the board through the specific areas. But I think it's, there are a number of areas where we have seen sustained performance, although that performance remaining below trajectory in a number of those areas, and there are some areas, particularly around some of the key metrics around performance, where we unfortunately are not seeing the change that we would want for our population. But we'll pick those up as we go through the report in more detail. But happy to hand over to my colleagues.
Okay, thank you, Gethin. If I could go on to 6.1.2 and go on to the quality performance section of the integrated performance dashboard. And I invite Greg Dix and Dom Herford to present an update on this paper, please.
I think Dom's going to kick off first, Chair, then I'll follow Dom.
Okay, thank you.
Is Dom there? Okay, if I kick off then, Chair, if that's okay, and then I'm sure Dom will follow. Just a few things, if I may, from my perspective. So in terms of serious incidents, they remain stable and within normal variation. Delays for treatment, regrettably, still remains our highest theme. And the work has now progressed on our community pressure ulcer improvement plans, with a specific focus on our DN caseload, where we are seeing patients come into our emergency department with the beginning of a grade 1 or grade 2 pressure ulcer. You may recall at the last board, and we just briefly touched on it, some of the concerns I had around falls, particularly within some of our front door departments or units and our older people's mental health wards. We've now pulled together all of the work that we started pre-COVID, and this is jointly led now between nursing and AHPs, so multi-professional forum. And in fact, just Tuesday, we had a spotlight on falls at the Quality and Safety Committee, where we spent some time looking at the work we've done to date and how we can better spread this across the organisation, including some of our third sector colleagues. We've still yet to nail down the measurement strategy for falls management, because I'm keen to ensure the board has better visibility of our improvement trajectories going forward, and equally how we use data in relation to monitoring falls per 1,000 bed days. We struggle with some data analyst support within the patient safety care team. I'm working with Stuart in that regard. Nevertheless, the two issues for me in this particular part of the report would be pressure ulcers and falls, and the improvement programs are now underway, and the next board will make sure we've nailed down the improvement trajectories. If I could just pick up on something in relation to complaints in George's absence. We were really struggling, as you can see within the report, for various reasons on our 30-day compliance indicator. It's back up to 60%, not where we need it to be, but nevertheless, there's been a lot of work within the PTR team and the ILG governance teams over the last couple of months. There is some detail in the report in relation to how we've changed the front end of our process to ensure that complaints that come in are resolved from an early resolution perspective, if they can be, because of course not all complaints, and in fact not all people that complain want a lengthy investigation. So we have really emphasised a different process at the front end of the complaint, so people can get an outcome much sooner than what they have done. We still have a fair way to go, and we did have a good deep dive into this at Quality and Safety again on Tuesday. And just finally, in terms of the themes, they haven't changed for a fair while. So communication, some areas around treatment are still concerning. It's really tricky to pull out specific themes from a communication perspective, because there are so many different drop down boxes in relation to how we monitor and record complaints on the current DATEX system. It will be much better in the new world of the new DATEX system, which we're currently implementing. But the PTR team have now interrogated some of the communication issues and will be doing some focused work. What I can say to the board is that we have seen an increase in complaints with patients coming through our front doors. So within our emergency units in terms of waiting and some of our assessment units. So that's all I wanted to say on my bit, Chair, if that's okay, and I'll hand over to Dom now.
Thank you. Dom?
Good morning, everyone. Apologies for being slightly out of sync with Greg on that one there. Just two things to bring to you here, which is the medication instance and our mortality rates. So please see after the discussion that we had last time with a rise in both our prescribing and our administration errors, actually they have fallen significantly, so actually in the medication administration errors, which is been given on the wards, given the communities and in our treatment areas. So that's good to see. It's over halved, which is over halved. It's just under half of the numbers we had before. It's going in the right direction. Obviously, still work to be done. Even one is unacceptable, but we are working towards that. The prescribing medication errors again seems to be quite stuck. That's something I'm really working with the doctors. Particularly, it's thanks that these numbers are falling due to the pharmacists. Most of these errors do happen on the wards. And so a lot of thanks really to the ward pharmacists who pick these up, who identify the issues as well, but they're not there 24/7, and it's often when they're not there that these errors happen. So we're working on how we can strengthen that out of that. The accrued mortality rates shows that there is a standard continuation of our rates. We are pretty stable in those at present. The one bit of data that's sort of newish that people will see will stand out here is our mortality rate per distribution. So compared with other health boards, we have a significantly higher, or looks like we have a significantly higher mortality rate. That is mainly explained by the fact that we include the palliative care and hospice service data within that, and that gives us a much higher number. There is also an established sort of known that our mortality rate tends to be on the higher end of normal when you compare our health boards, and that's due to the population that we serve and the deprivation that we have there. So even though that is a difficult rate to accept, and I'm not saying it's something we should sit on our laurels and go, that's the rate it is, still lots of areas to tackle and work on, but it is staying relatively stable at the moment, and that's reassuring. Any questions really? No, nothing more to add.
Okay, thank you, Tom. Thank you, Greg. I've got a question from Jane Sagro. Jane?
Thank you, Chair, and thank you, Greg and Dom. Just to confirm, Chair, that the Quality and Safety Committee is looking at falls and pressure ulcers, as Greg has already outlined. Question for Don, really around medication and prescribing, and it may also involve Stuart, I guess. I mean, currently we don't have a digital solution to support prescribing, and that obviously would help reduce the numbers of prescribing errors. I know there's national work ongoing on that. Do we have any indications of when we're likely to have the support of that solution to help support our staff and reduce errors?
I was pretending for a delay then in case Stuart came in to be able to say on the actual number. Let me just sort of say it is obviously the direction. This is how we go about tackling this problem. And when you get to a sort of a state where you're not improving, then there's something else needs to give, and it is digital prescribing is going to be the solution to that. It's going to be an area where we introduce it in areas that in certain patches. There's not going to be a whole rollout across everyone in one go, but it's targeting those areas that we particularly have a problem with. And to me, the solution would be it's out of hours, it's with GPs as well, and with the primary care prescriber, that would make a significant difference for not only just in terms of efficiency for them, but also in terms of patient safety. So that if I could choose one area to put it in, I'd have it all straight out to primary care immediately. But Stuart's going to tell me we can do that in the next week, I think. No.
Stuart.
Thank you, Chair, and thank you, Jane, for the question. And unfortunately, Dom, no, it won't be in the next week, I'm afraid. But in terms of your point around the national work, there is an ongoing procurement to get a number of suppliers onto a framework. So actually, that we're not dependent on one specific solution and if you like, an iterative rollout across health boards, so we can move at a pace that's appropriate to us. And clearly, there are significant priorities around this. This will require some funding, though, and I think we've got a business case that is in draft to submit to Welsh Government. But once that procurement is complete, we can then move forward as subject to getting that funding, I suppose, in terms of an implementation team. This isn't significant. While there's significant opportunities, not clearly safety opportunities, there's much broader transformation opportunities as well, again, in this, and would be a top priority for us. It's a top priority for obviously government and ministers as well. So I would envisage that, subject to a completion on the procurement, which is due now, there have been some slight issues. So there is a procurement exercise due to finish in September. So we'll have a clarity around the options available to us on a framework, and we can take it forward from then and work out a timeline, obviously, that's appropriate for the organisation.
Thank you, Stuart. So that's good news.
Any further questions or comments? No? Can I just ask a question around pressure ulcers, if I could, Greg? I noticed that there was in the report, it makes reference to an investigation that was completed, and there were 250 recording an outcome of avoidable pressure areas that were avoidable. Is there are we aware of what the main reasons are, I suppose, of this at the moment, or what might be the causes?
Yeah, there are different causes, Chair, within the community and within our inpatient settings. I'm probably more worried about our community settings. So I guess a couple of reflections. The first being during the challenges with COVID, where we were struggling with capacity from not just a DN perspective, but as Sharon alluded to, nursing capacity across the health board. There were some patients that had limited visits across our communities to ensure we balanced the risk across we have about 1,500 contacts a day. So one could draw a conclusion that the limited district nursing visits contributed to, pressure area care. We do have some very complex patients that our DNs have been caring for a long while. And certainly through some of the scrutiny panels that we have for both falls and pressure ulcers, there has been some challenges with some patients ensuring they're relieving their own pressures if they can. So I hate to say the word non-compliant, but I can't think of a better word at the minute. So patients that are encouraged to relieve their own pressure, and for various reasons they can't. So I think they're the two key points from a community perspective. From an inpatient perspective, where again through the outcomes of the scrutiny panels, we've still got some way to go in relation to regular assessment. So we're pretty good at assessing on admission. but regular assessment through the inpatient journey, again, has been a challenge for us. So what has been really helpful from a pressure ulcer perspective is Improvement and Innovation CTM have interrogated all of our data over the last 3 years. So we absolutely know, where we need to drill down in relation to the improvements we need to make and which part of the system. But I think probably they're the 3 points of reflection. I've hopefully responded to your question effectively.
Thank you for that, Greg. Obviously, my reference was to the investigation, I suppose, and it's good that we did the investigation. That's the positive thing, and taking the lessons from there. And obviously, we've got controls in place to measure how things are going forward. And similarly, if we had if there were major concerns again, I assume we would do another investigation again if that was the case.
Of course, yeah, and all pressure ulcers that are deemed avoidable go through a scrutiny committee, which has representation from our tissue viability nursing team now, so they're back on board with that. So, and I've attended a couple myself, and they are very robust. And so I have confidence now in relation to the data that comes through from an avoidable perspective. But again, we need to work on the continued assessment process, I think.
Okay, thank you, Greg. Well, thank you, Dom. Thank you, Greg, for your overview. Can I now go on to 6.1.3, and it's the Operation Delivery Performance section of the Integrated Performance Dashboard. Can I invite Gethin Hughes to present members with an update on the delivery performance section, please?
Thank you, Chair. I will take the performance dashboard as read, but we'll draw out some key aspects for the board today. I think the overall statement is that operational performance is significantly challenged across all the domains within the health board, and this is a real focus now for the operational teams to look at how we address those and to start to move into a more positive area of performance. So in the first instance, I'll talk briefly about planned care. There are a number of sort of initiatives undergoing with planned care, which I will address within the presentation that I'll be delivering later on the agenda. So I won't go into those in great detail now. But I think the important thing to note in planned care is that the growth of our waiting list has now stabilised. So we have seen our total waiting list now stay in balance for the last couple of months, which is on page 17 of the report. And that we're also seeing a reduction now, although small, it is welcomed, in the number of patients, our longest waiting patients, so those who are waiting over 104 weeks. And so that that is good news. But I think, in terms of drawing out really the challenge of elective performance to board, by the end of this year, we are due to deliver no patients waiting over 104 weeks for treatment. Currently, we have 13,500 patients in that cohort at the moment in the health board, and equally in terms of bringing down for the wait for a first outpatient appointment to 52 weeks. And again, at this point in time, we have nearly 20,000 patients who are waiting over 52 weeks for their first outpatient appointment. So there is a significant challenge within that. So we have got plans and we've got detailed trajectories now across all of those specialties where we will be able to identify where those key risks to delivery are, and I intend to bring those back to the committees next month. But it is really important that I guess we recognise the scale of the challenge within the health board to deliver those. But there is strong commitment. We have seen some important first moves, I guess, on a number of those areas, which I'll touch on later, which I genuinely believe will start to make some inroads into those and allow our patients to access the care that they need. Linked to planned care is the position on endoscopy, and this remains a key concern for me and colleagues on the exec team. So endoscopy is a key diagnostic for both routine elective patients, but more importantly for our cancer patients. And we currently have several thousand patients waiting over 8 weeks for that investigation. Now, part of what we're looking to do is move some patients across our capacity to level out some of those waiting times, and we're also mobilising an additional endoscopy theatre, which is a mobile facility on the Royal Glamorgan Hospital site. There have been some challenges with that. They are new to the UK, and there are some challenges about their compliance to health building regulations, which we're working through. I've got a call with the company later on this afternoon where I hope we can now get a firm date for the works to have happened, but that will then allow us to put on additional endoscopy capacity as part of our recovery plan. Staying then with cancer as part of planned care, so our unvalidated position is slightly better than that in the report. So for April, we're now at 50.4%, which is a slight improvement on that reported. So there is a commitment absolutely in terms of the minister's ambition around cancer and moving towards an 85% compliance with the 62-day target, and that is probably going to be for March 25. In terms of our staging post for that, we have now developed trajectories for each of our tumour sites, which will allow us to get to 70% compliance on 62 days by March 23, so the end of this financial year. We have seen some really good progress in breast, where there's been some very well supported improvement work, and we've managed to secure additional appointments in breast surgeon and breast radiologist and breast physician, which nationally are really hard to recruit posts, and I think it's really positive that there remains really strong interest in the breast service in Cwmtach Morgannwg. We have seen that backlog reduce from by nearly, well, over 300 patients in the last sort of 6 weeks. So again, a really important improvement in there for our patients. I think it is really crucial, I guess, though, in terms of those trajectories, that board notes that the overall performance won't improve for many months, because we've got a large backlog of patients to sort through who have already passed their breach date of 62 days. So we're taking a sort of a two-pronged approach with cancer. The first is around trying to make sure that those patients that are being referred we're seeing within 62 days, and those patients that remain post 62 days, we've got very clear clearance plans for those. I'm chairing thrice weekly meetings with the ILGs to go through those patients name by name, to make sure that we've got clear plans for managing them through their pathways. One of the key constraints, though, on cancer recovery is our pathology capacity. And we've had long conversations about this within the executive team. We have made a further investment in pathology for additional outsourcing of routine specimens, which allows us to manage more of our urgent cases in-house. And that's driven by both a capacity constraint within the pathology team, but also increased demand as we ramp up our activity as part of our recovery plans. So whilst we've done that as an immediate support to the service, Lauren Edwards and I are working with the pathology team and the Rhondda Tafili ILG to come up with a more sustainable plan for workforce within the service for the next few years, whilst whilst we also look at the longer term solution regionally, as Paul alluded to in his chief executive's report, around pathology services across South East Wales. I'll now move to urgent care. I think we're all aware that the pressure on our emergency services remains very significant across the whole health board. And you'll see within the key metrics that there's been little improvement in 4-hour performance. We have a slightly deteriorating position in April on 12-hour performance of patients who require admission. And I guess the main concern that all of us have is around the delays to handing over ambulances in a timely way. And particularly the impact that has on both the patients that are waiting on the ambulance, but more importantly, those patients in our community for whom then there is a delayed response. So we have established an improvement board for urgent care. Operationally, that is now chaired by Dr. Anthony Gibson, who ILG director for Bridgend. And is supported by Sarah James, the Deputy Chief Operating Officer for Acute Services. And that is built around the 6 Goals programme, which is the Welsh Government programme around improving urgent care within Wales. Our top focus initially, so that has there are 6 streams to that programme that set out, from admission avoidance, how we look after people within their own communities through primary care, through to the back door, and how we improve flow out of our hospitals. Our immediate focus is on exit block from our department. So the key issue for us in terms of offloading ambulances is we continually have a number of patients in our A&E department waiting ward beds. So that's got to be our first priority, and that's primarily being driven around our discharge profiles from our 3 acute hospitals. So we know that our discharge profile is too late in the day to meet the demand curve for ambulances and bed requirements. So we need to shift to much earlier in the day our discharges. So there's an awful lot of work going on in terms of internal processes, on board rounds, using SAFER, making sure that we know who's going home tomorrow, who's probably going home the day after, and making sure all of the things that need to be in place are there so that those discharges happen and happen early. The second bit linked to that is the work that we're doing with our colleagues in local authorities, and you'll note on page 26 that CTM is an outlier compared to the rest of Wales on the ratio of patients waiting packages of care. So Paul and myself had meetings yesterday with CEOs and directors of social services from the local authorities, looking at what immediate capacity can we add to the system to support, to address that, and what are the longer term models that we can look to utilise to ensure patients go home more quickly. The second element, of course, is around looking at the current alternative pathways that we have for conveyance to hospital and to admission, and making sure that we are caring for patients in the most appropriate locations. For a number of our patients, it isn't always appropriate for them to be conveyed to hospital, and there are alternatives. We've heard about the heart failure service this morning, and I think it's making sure that they are robust and available for our colleagues in WAST. But clearly the focus on this is significant, and we will bring further updates to both the performance subcommittees but also the quality subcommittees on how we're managing both the risk to handovers and those patients that are experiencing long delays waiting for admission into our into our A&E departments. And then briefly, just picking up on some of the key mental health and CAMS areas. So psychological therapies are a key issue. you know, we know from all the population health data that depression is such a high contributor to the number of patients with long-term chronic conditions and the impact that has on cost. So it is really important that we look at how we develop both our formal psychological therapy service to meet that demand, but how we also have services that people can access more locally. In terms of CAMS, the SPA has now gone live for Swansea Bay, and that is having a positive impact in terms of access, and we'll continue to monitor that closely. We have got a number of new roles being recruited to for that CAMS, that element of the CAMS service, but that remains a key focus for the team. And the final service where this is driven very much from a very historic demand capacity mismatch, pretty much from the conception of the service, and that's the Neurodevelopmental Service, and it is that remains we've got to do a lot of work really to understand how we can make that service work in a way that meets the demands being placed on it in a better way. And as the board will be aware, we've continued our relationship with Halcyon, who provide an alternative service when signposted by our neurodevelopmental team. Just noticing in the question around discharge lounges, so we do we are looking at we've got a plan to establish a discharge lounge on the Royal Glamorgan site. We do have discharge lounge facility at Princess of Wales, and we're looking at a location at Prince Charles. Space in Prince Charles, as people will be aware, with all the building works, is a constraint. The really important bit, though, discharge lounges are only as good as they are as if we've done that proper preemptive discharge planning, so that we know 24 hours in advance, because otherwise patients just end up spending a long time waiting for their TTOs. So it is that within 48 hours notification of patients become a potential discharge, just becomes the really crucial factor in there. But happy to take any questions, Chair.
Thank you, Gethin. Are there any questions or comments colleagues would like to make to Gethin on this presentation? No, it seems Gethin, obviously there are no questions or comments there, but you've given us a very clear overview of our position, the challenges we've got, and what we need to do in both the short term and the long term. So, it would seem as well we've got the right measures in place to help inform on our progress in relation to performance. So thank you very much for that, Gethin. Okay, if I could then move on to item 6.1.4, and that's workforce section. If I invite Howell Daniel to present members with an update on workforce performance, please.
Thank you, Chair. Again, I'll assume that members have read the report, but there's just a couple of things I just wanted to mention. Should also mention that there is a much fuller people metrics report which goes to the People and Culture Committee on a quarterly basis and has a full discussion there as well. But just a few things in relation to the metrics in the integrated performance report. So you'll note again a very challenging position across all of the people indicators. We've had a very difficult couple of years across most of the people domains as a result of our experience during the pandemic. Just a couple of things to highlight. So turnover has increased fairly sharply this month. So we're just in the process of trying to understand that as a 1 month indicator. But the indicator for turnover more generally is in an upward trajectory direction. There are a couple of main reasons for that. One is around retirement. So where people had delayed their retirement date in order to support during the pandemic and are now retiring, and also one particular area which has been highlighted by staff and indeed our trade union colleagues via various trade union colleagues is around flexible working opportunities. So we do plan to do a specific piece of work on flexible working over the next year. Just on retention more generally, We have a number of activities that we are undertaking at the moment in the Health Board that are geared specifically towards retention. So they are our work on employee experience, that is improving the daily experience of our people through processes and various other things. Progressing our work on our policy agenda, so making our policies more people friendly. So for example, the recent policy development we've had in terms of a pregnancy loss policy, and we are also exploring neonatal leave policy, so much more progressive policy agenda. There's also then the work we're doing on leadership and management development to ensure that our all of our staff are well led and are well looked after by their leaders and their managers. And also then probably one of the main drivers of a lot of these metrics is the work we're doing around workforce planning, which is a considerable contributory factor to some of the workforce pressures that we have. So the vacancy levels that we carry within the Health Board, and while we have done some really good work over the last couple of years around international nurse recruitment, and that has made a dent in our vacancy rate in nursing, we still do carry a significant vacancy rate in nursing and significant vacancies in medical specialties across the Health Board. So we are working on that because that inevitably will contribute towards levels of sickness absence and indeed turnover. On sickness more specifically, so these are March rates, so they are 2 months behind, and that's a symptom of the pay run and how that works. But essentially what you'll probably be seeing here is the last elements of the Omicron lag in terms of sickness absence rates. They have dropped in this March period from a peak of around 9.5%. Which is clearly an extraordinary level of sickness for us compared to our normal sickness rates for the Health Board, which usually were around about the 6% mark. So I would expect to see sickness rates come down further in the following months. However, whether they will normalise back to our previous position is another matter, so we'll keep an eye on that. We will be having conversations over the next couple of months about our approach to how we deal with sickness absence. So again, taking a more compassionate approach to supporting people, particularly when we know that there are significant issues around stress and anxiety. So we have, as you know, Chair, developed significantly our wellbeing offering, but we also know that it is a very difficult time and a very pressured time to work in the healthcare system. So we need to do all we can to support our people through good management and good leadership, but also some of the measures that I mentioned earlier on in terms of supporting the workforce. Just a couple of other things, more performance related things. So we've done a huge amount of work over the last couple of months around staff and man training to try and remove some of the obstacles. So making the systems easier to access, and also attempting to simplify the Stataman training regime. We're not yet seeing that come through in increased rates, although they are stabilised and the decline has arrested. So again, that will be a key focus for us, and it will be a focus of the performance arrangements we put in place as part of the new operating model. And similarly with our PDR process, you'll see there that essentially what our data tells us is that 1 in 2 of our staff haven't had a PDR in the last year. Now, we're clearly not at all satisfied with that. We in February launched a new PDR process, Your Conversation, which is much more simplified, focuses on values and behaviours and also well-being conversations. What we really need to now do is get that out there, make sure it's being used, and we have a review process within a couple of months just to see how that process is going. But again, that will form a key part of the expectations in terms of the new operating model. Dom may wish to say more on this, but while there is a slight dip in job planning compliance from March to April, the overall trend is upwards. And again, there was a fuller report as well as an audit report presented to audit committee on that more recently in a full discussion. but some of the metrics, the latter metrics around direct engagement and off-contract agency fill are directly connected to some of the workforce pressures we've had, particularly, as I said, coming out of the tail and the lag on operational pressures, and indeed the Omicron variant. So that's probably all I wanted to say there, Emrys. So I'll take any questions from colleagues.
Okay, thank you, Howard. Any comments or questions for Howard? No questions or comments. Thank you, Howard, for your presentation of the paper. Can I then go on to 6.1.5 and come on to financial performance, please? And I invite Sally May to present members with an update on the financial performance section of the report, please. You're on mute at the moment, Sally.
I'm surprised by seeing month 1, so I just need to deal with month 12 first briefly. So month 12 report, we reported a draft surplus of 37k for the year, which would achieve the financial break-even duty. That means that we're currently subject to audit, and we presented the draft accounts to the audit committee the week before last. So in process, lots of work ongoing around audit, but a good outturn performance in terms of revenue. Savings performance was less positive. So we achieved 11.5 million, the actual savings were 12.5 against a target of 14.5 million in year. But the recurrent savings sat at only 5 million, which gives us shortfall going into next year against the overall target of 16.1, the full year effect target, a shortfall of 11.1, and that impacts into our month 1 performance. Underlying position, we'd expected to be at 31.4, and the change in terms of savings delivery moved our recurrent deficit out to 44.5 as at the year end. That's obviously a significant concern and does again impact. And capital, I have to pay particular tribute to our capital team. We had expenditure of 79.2 million in year, which is a huge capital programme, and we reported a draft surplus of just 42k against this capital resource limit. That was a huge and complex process to arrive so close to the CRL. Is a testimony to the hard work of the estates and capital teams. And then I just want to draw people's attention to the COVID expenditure during the previous year, which was 114.4 million of additional revenue funding that we received. Now, in terms of the month 1 finance report, which is up on your screens, I've changed the format of this quite substantially to try to with lots of feedback from board colleagues around how they'd like to see the finance report looking for the future, so that it's clearer and more accessible for people. So this is going to be an iterative process, but hopefully this starts to do that. If I just draw your attention then to some of the main issues for month 1 and just talk about the situation. So we submitted our draft financial plan to Welsh Government alongside our minimum data sets on the 29th of April, and that was analysed into 3 elements: core, exceptional cost pressures, and ongoing COVID response costs. The planning assumption was that that we've been asked to work with is that there will be funding that follows for the exceptional cost pressures and ongoing COVID response costs. But I do have to draw the board's attention to the fact that at this point we've been advised to treat that as a risk in our financial plan because the income is not yet confirmed. So that is something we'll need to keep an eye on during the year. Our core plan submission was a deficit of 26.5 million, and that failure to submit a financially balanced plan is a breach of our statutory duty, and we'll deal with that a bit later when we come onto the annual plan submission. So that deficit core plan requires us to deliver a savings of 17.3 million. Plans of 14.3 have been included on our core plan, and further work is ongoing to close that remaining 3 million gap. In addition, recovery actions are required to address brought forward cost pressures of circa 11 million. Meeting all of those requirements is a step change in our savings delivery, and we'll need to track that really carefully during the year. So we've assumed the additional allocations, as I said, and left them at risk. There are other residual risks and uncertainties spanning all elements of our plan, including inflationary pressures that we can see across the general economy. And this is a sort of a difficult financial year. At this point, our plan can't be approved because it's a deficit plan, but that's what we are monitoring against. So as at month 1, we're maintaining our core forecast deficit at 26.5 million. We're forecasting a reduction in exceptional costs compared to plan of 1 million and forecasting an increase in COVID response costs of 3.4 million compared to plan. Largely that reflects additional costs in the first month around staffing from enhanced pay rates and some of those issues we talked about a little bit earlier in terms of the board sort of the Nurse Staffing Act and the temporary changes across wards. So in terms of our overall performance, we are monitoring against our draft plan. There was a small adverse variance at month 1 of 154k, and we'll continue to monitor through the year. I think what's important to say is our run rates remain high, and there is going to be a considerable challenge in managing our expenditure down. It's clear there's an expectation as we move out of the COVID phase, and with recent revised guidance about changes in IPC guidance, for example, there's an expectation that expenditure on COVID and on our COVID response costs will start to reduce. That's really all I wanted to draw people's attention to at this point. I wasn't planning on going through it as a presentation, Chloe, but so if you want to drop that down now, that's fine, but happy to take any questions.
Thank you, Sally. Patsy.
It's not a question, just a comment really to say I think the new format for the report is much improved and much easier to read, and I'm sure if you're not an accountant you will now understand it much better and get to the end of it. So thank you for that, Sally.
Okay.
Thank you. Paul?
Thanks, Emrys. I just think we just need to reflect the fact that this is a significant challenge now for us moving forward. Sally mentioned that we've already got some scrutiny going on from Welsh Government around our financial position, and I think it's really difficult at a time when we've been rightly so focused on dealing with the pressures of COVID, and we need to reflect that also we're still dealing with a lot of very challenging operational situations at the moment, and it's a big ask now to turn the ship around really and start to get everyone focused on how we drive efficiency and productivity through our services. Just to say also that there is similar challenge across the rest of many of the other health boards in Wales as well, and I know, Emrys, I'm sure you've had these conversations with chairs meetings as well, but certainly yes, the NHS Leadership Board this week, it was flagged there are some significant issues across the whole of the NHS in Wales, and I think there's a delicate balance here in both internally and externally about how we position the financial challenges we're facing and the need to drive efficiency, with also obviously recognising that we are still needing to do some significant work to catch up the backlog. We've got unscheduled care pressures, etc. So I just think we need to be alert to the fact that there's some careful handling, I think, internally of this, and I think we've been giving some thought as an exec team about how we focus down on some of the core corporate programs of work that need to happen to drive our savings programs this year, many of which are actually linked back to some of the earlier conversations about things like workforce, because if we can reduce our agency and temporary staff bill, that will obviously help fill vacancies, but it will also help improve quality of care. So there is a story to tell about how we are aiming to achieve this, but I just wanted to flag that I think it poses quite a significant risk for us now as we start to come out of the COVID period.
And we had, as Paul says, our deep dive with Welsh Government colleagues yesterday, where we went through and explained how we've moved from our break-even position for last year into a recurrent deficit position. I think we've tracked through that very carefully, and I think they understand the movement. Nevertheless, they are expecting us to develop our plans to address it. We also have, so we've started to build our value and effectiveness work streams, which include medical and nursing productivity, as Paul says, which are about trying to address those very issues. I think we just need to recognise that, as he says, this is going to be high risk, and we'll need to move into delivering savings and gaining confidence that we can get our finances back onto a sustainable position. So it will require quite careful handling through the year.
Thank you, Sally. If I could invite Carolyn in, please.
Sorry, I couldn't get my mic off then. Thank you, Chair. Sally, I echo the comments about the report. It's very, very helpful and much clearer, so thank you for that. I just wanted to ask you specifically about energy costs, because I was surprised to notice that there was a comment about energy costs have been forecast to reduce following negotiation of contracts. And I just wondered if you could say a bit more about that, given all the news about energy costs and how much of that is actually factored in at the moment.
So energy costs sits within that exceptional basket, which is where we are currently assuming income but at risk. We have sort of two components really for CTM. One is Prince Charles, where it's subject to a sort of PFI type agreement around a combined heat and power, and we're required to go through a company called Veolia to secure our energy deals. Recently we agreed, because obviously things started to become volatile during last year, and unusually the agreement to a new contract was in the winter each year. So last autumn we agreed a 6-month deal which takes us to May, and we've recently agreed a further 12-month deal, which was fortunately at a point where the prices were slightly lower. But trying to secure deals is really, really difficult. Even as somebody's quoted you something, it'll be gone 5 minutes later. For the balance of our energy, it's secured via shared services and via an all Wales procurement. There's a group that is chaired by Avion Williams, who was formerly a finance director and specifically runs this group looking at energy, and they buy ahead on the market. So during the last financial year, there was a degree to which they bought ahead, which protected us from the worst of the sort of increases at a point in time. But they're still working on their strategy. So each it does move around very rapidly. So they've only bought ahead portions of it. I can share some of the detail if you're really interested at some point. But it is, I think it's fair to say, highly volatile, and we'll have to see what happens during the year.
Thank you.
If I could invite Linda in, please.
Thank you, Emrys. Thank you, Sally. Hearing everything that you say, and obviously appreciating this is a really difficult situation. So, you know, is there anything in additional as an independent member that I and other board members can do to support the executive during this time? Because obviously I know we've got all of the normal scrutiny and everything like that happens at the various committees, but if there is anything, you know, please can you consider what that might be, because I'd be very happy. I feel a bit impotent on this one, to be honest with you. So if there is anything, please just shout.
Appreciate that. I think what we need to do is sort of continue our focus and to think about how we can develop intelligent savings, ones that hit both the sort of cost reduction and quality aspects, and therefore deliver better value. And I think we all need to focus around that.
Paul?
Just following on from Linda's point there, I think there is also something about how we use the relevant committees, and I know Sally will be doing this anyway, but you know, this isn't just a finance committee issue. This needs to be, you know, we need to be thinking about how we're scrutinising the efficiency and savings plans, and I think we need to probably think about how we present, for example, in the board papers, our trajectory around savings and the key programmes of efficiency that we're planning, and present back to you about how we are on track, off track, to give you as IMs the opportunity in the broadest sense of IMs, not just Patsy as the finance lead IM, to be able to sort of question and ask us to explain where we are on those key programs of work, because I think I can anticipate that we will be asked by Welsh Government to describe how the board is being kept appraised of the challenge, and also scrutinising performance against savings and efficiency programmes. So we might want to have a chat, Sally, I think perhaps about how we build some of those reporting mechanisms into the finance reports to enhance what's already in there.
Yeah, I mean, for month one, it's clearly a summary, and we need to build the programmes of work for the value and effectiveness in terms of, you know, what the potential size of the opportunity is, and then some of the milestones in terms of moving from sort of aspiration to delivery and the timelines around those. So yes, I think it probably needs a wider piece of reporting around that. This is very much a summary approach at the moment.
And just to add to that, noting Paul's comments and what we've heard in our agenda today, you know, achieving integrated governance around finance, quality and access is a big challenge for us going forward, and we need to, and obviously we need to ensure that we have the systems and processes that we do have in place are helping us to, well, one, performance manage what we're doing, and certainly having the right systems and processes in place to assure that we are delivering what we're required to deliver, recognising there are some tough times ahead. But thank you for that, Sally. Okay, can I go on to the next agenda item then, please, which is the update 6.2, which is the updated annual plan. And I invite Claire Nelson to present the report, which members have been asked to discuss and note. Welcome, Claire.
Thank you, Chair. So I'll do it in chronicle order, if that's all right. So we'll do the annual plan 2021 update on deliverables. So we've been asked to do this as part of the Welsh Government reporting and with the audit Wales as well. So members are asked to note the update at a high level. We've RAG rated across the chapters what we set out to be the deliverables. We've highlighted a number of areas that were not progressed as well, and some of those are well documented and we've heard about them today. So those particular ones around planned care recovery and financial savings plans. I think where they reported deliverables, we also included where that was reported back to the various board meetings and subcommittees, I think for an audit trail as well. So I think that's a pretty straightforward report. And then the second paper is the updated annual plan for 2022-23. So members might remember that they were asked to receive a note back in March, on the 31st of March, and we submitted that paper to Welsh Government. We highlighted at the time that it needed further work in terms of a recovery plan, which was agreed with Welsh Government earlier in the month, and we had an extension to the end of April. So this is that plan which was submitted on the 29th of April. The main changes or additions are on pages 31 to 38 for anyone who's in depth on that, and it sets out how we plan to meet the ministerial measures, how we're using at a high level our 26.1 million, which is our allocation for planned care recovery and sustainability from Welsh Government. We also included as an appendix, I'm not sure it's work translated with the papers, a minimum data set, which shows our forecast of performance across a number of areas. So it's alignment of workforce and finance, along with a number of deliverables across many specialties, mental health, our planned care recovery and scheduled care primary care. There's also an updated financial report was submitted, which showed a reduction in the core deficit, which I'm sure Sally might come in and report on. We will also be reporting quarterly on our delivery of this plan back to board and also to Welsh Government. Feedback from Welsh Government is expected in June. We did have a peer review this week on a planning level, which fits nice, I think, with the next board paper. So there's the highlights of the positives of the plan, with that it was clear on priorities and the links with strategies and local goals. And collectively, we'll be pleased to hear that we had the strongest population health direction and life course approach. So that was commended from all the health boards, trusts and national organisations in Wales. So yes, members are asked to note the plan, but I'm not sure if Sally wants to come in on the finance as well.
I think we've probably dealt largely with the finances in my description around the month one report. We also, as I said, we also had our sort of deep dive into our finances yesterday. I suppose it's just important to note that at this point, because it's a deficit plan, we can't approve it, we can only receive and note it. And other than that, I think I haven't got anything further to add at this point.
Are there any comments or questions for Claire? No, I think you described that very well, Claire, and I know that there's a lot of work that's gone on up until now and involved the board in getting to where we are today. So thank you very much, Claire, for giving us the Okay, my next agenda item is 6.3, which is population health reports. I think before I ask Kelechi to give his report, I think it's worth also recognising the comments that Claire just shared with us on the previous item, where as a health board and the work that was done on population health was seen as the best in Wales. So well done to Kelechi and his team. Excellent. Can I then ask you then, Kelechi, if you could give your update in respect of the population health report, please?
Thank you, Chair, and thanks for that. Great credit to everyone across the organization. This is an excellent team effort we're making here. So good afternoon once again, everyone. The purpose of the population health report is to present to the board for discussion progress with programs of work within the population health umbrella as we transition away from the response to COVID and hopefully not onto monkeypox. The health board continues to deliver a COVID vaccination program in accordance with JCVI and national guidance. So what the paper does, it is highlights the focus of the program, principally being that of leaving no one behind and tackling issues of vaccine equity. It also summarizes findings from a recent staff and community survey of flu and COVID vaccinations, and we will obviously be taking those into account as we shape the program for the autumn and winter. The board may be aware that we were intending to develop an integrated directorate to take forward COVID testing and immunization for vaccine preventable diseases and COVID testing as well. But whilst not abandoning the proposed structure and approach, financial constraints that have been well rehearsed in this forum mean that we will need to calibrate the evolution of the directorate with the provision of additional sustainable funding from the Welsh Government, both for testing and vaccination. I know that we've recently had confirmation of funding for testing, but national conversations are going on around vaccination. The paper also summarizes progress with our population health organization program, particularly highlighting the extremely positive commitments of independent members of the board to systems leadership in the population health and health inequalities space. I think in an organization like ours, which self-identifies as a population health organization, the responsibility of providing good quality reactive healthcare services to sick populations must be balanced with active health promotion and disease prevention targeted at entire populations. So it is exemplary and very pleasing in my view that the board is committed to this. As part of the Population Health Organization program, we were very explicit about the goals of our population health system. The report signals partial fulfillment of our commitment to set out the baselines for key indicators associated with those goals and how we will hold ourselves to account for delivering on these over time. Initial outcomes from our population health management program of work are also set out in the report, highlighting the importance for us of multiple morbidity and the plans to action the insights we're getting from the integrated data that we now have on the CTM population. As I know the board appreciates, obesity is a principal challenge for Cwmtaf Morgannwg, and this report therefore goes into a lot of detail on the variety of initiatives across communities and healthcare settings, tackling the 66% prevalence of overweight and obesity in our communities. Most notable in this regard is the integrated level 2, level 3 weight management service, which we now expect to be up and running in September of this year. I think given the incredible financial constrained environments in which we are currently operating, I think this service is a clear demonstration of the commitment of the health board to population health and to the well-being of future generations' 5 ways of working, thinking long-term, integrating services, focusing on prevention, involving communities and collaborating with other stakeholders. So lots of credit to exec colleagues who are absolutely supportive of us getting this service up and running, despite the pressures and challenges that we had in terms of resources. The report looks at progress on 3 of the minister's measures, which relate more directly to population health and key areas of focus in respect of those. Specifically, the areas of focus including strengthening our supports to expectant mothers who are smokers at booking, tackling overall smoking prevalence in Merthyr and implementing an Ottawa-style smoking cessation service in our healthcare settings. Finally, the board is just asked to note progress on the planned 2P transfer of the local public health team from Public Health Wales to Cwmtaf Morgannwg University Health Board, and that's scheduled to take place on the 30th of September 2022. Chair, I'm happy to stop here and take any comments or questions. Thank you.
Thank you, Kelechi. Are there any comments or questions for Kelechi, please? Yes, Ian?
Yeah, thanks, Emrys, and thanks, Kelechi. Just an observation, really, rather than a question. Great to see the direction this is going in, but a lot of the data I notice in the actual report itself is very Cwmtaf centric rather than Cwmtaf Morgannwg centric. And it's just an appeal, really, that in the future can we maybe include more data from the Bridgend area. Because we've had discussions previously in the past, obviously, and we know that since the merger a few years ago that the people in Bridgend can feel a little bit sort of left out of things. And I think that sometimes, and you don't do this, Kelechi, I know you don't, but there's an assumption sometimes that Bridgend is the affluent part of Cwmtaf Morgannwg, and that's certainly not the case. And some of the valleys going up from Bridgend have lots of the problems that the Cynon Valley and areas of Merthyr have as well. So just an appeal in future if we can maybe include more data from the Bridgend locality and its environment.
Thank you very much, Ian. That point is noted. I mean, sometimes we do face challenges with disaggregation of survey data, and a lot of the data we present in public health are derived from surveys. So sometimes there's a bit of disaggregation challenges. But despite that, I think we do have a lot of Bridgend data, and I'll take that point away. So thank you.
Thanks, that's great.
Thank you, Ian. Thank you, Kelechi. If I could invite Patsy, please.
Yeah, just a quick one, Kelechi, a really helpful report. But of the 37 actions outlined in the Population Health Organisation paper, I think it would be helpful for the board to receive a summary of the 37 and where we are against them. So a RAG rating and a trend. Don't need a huge report, just very much a summary with a RAG rating. Thanks.
Thank you, Patsy. I'll take that action away. That's very clear ask, and we will get that back to you. Thank you.
Okay, there's no further questions or comments there. Can I thank you again for your report today, Kelechi? And again, I must have to to stress again about how well you and the team have done in taking a lead in population health. Well, okay, if I could go on to the next item, please, which is 6.4, and it's the CTM operating model, and it's a reconfiguration proposal. And I'd like to invite Paul Mears, our Chief Exec, to present the report, please.
Sorry, thanks, Chair. I'm just actually going to ask Richard to come in a minute and give an overview of where we are with the programme. But just to say, as an intro, as board members will know, we've discussed the current operating model and the options for developing and changing that model in light of some of the pressures we're facing now in the post-pandemic period, and some of the learning and experience of working with the previous model. I think it's fair to say, and it's interesting, we were having that conversation earlier with Anna, around the advisory group. There's been lots of views and feedback expressed from a number of people from across the organisation. So Richard is coordinating the approach at the changes with colleagues from a range of other corporate teams and the operational teams as well. So I was just going to ask Richard just to quickly take us through some key points from the paper.
Diolch. Thank you, Paul. Thank you, Chair. So I'll run through sort of where we are, and board members will be aware that Paul delivered an update on this back in March, and Paul touched on the sort of the rationale, which I won't sort of go through today, but the paper is there from March if any board members want to refer back to that. So really, in outline, the care group structure was proposed and is proposed, going through planned care, unscheduled care, diagnostics, therapies and specialties, mental health and LD, as well as primary and community care. Women and children's care group is also proposed, and after some feedback, which I'll come on to later, actually, it's been proposed that that care group be named families and children's care group to make it more inclusive. So that's it's good feedback, well received there. Since the last board meeting, we were in a sort of an engagement phase, I'd say, at that point, and talking to a variety of staff, those that were impacted, those that potentially were less impacted or not impacted, and from doing that, a sort of a consultation document was drawn up. So this is a sort of 60-70 page document which covered off the proposed structure going forward. On the 9th of May, as planned, that was released to the wider organisation for comment and sort of feedback. And so clearly we're now sort of in the consultation phase as per the sort of organisational change policy sort of guidance, a 4-week process, and all being well, that will finish on Monday, the 6th of June. So as we've been going along, we've been getting feedback, and Anna helpfully sort of touched on the clinical advisory group earlier on in terms of that sort of dedicated or semi-dedicated session for the operating model proposals. And I think in general, the feedback has been really positive. I haven't met anyone that says this is not a good direction of travel to go in. I think people understand the rationale and people understand where we need to go. And the ILG teams have done a fantastic job over the last sort of couple of years. But now as we move beyond sort of COVID and with obviously the pressures that Gethin outlined earlier in his operational sort of performance update, this model has been well received to be able to put us on a good footing to take us where we need to go. It's also worth noting, I think, and I know Paul's mentioned this a few times now, that operational and organisational structures are important, but the ways of working, and the way we collaborate across different sort of boundary areas and between different services is probably more important to make sure that we are trying to make use of the fact that we are an integrated health board. So I think that'll be really important in terms of making sure the ways of working are correct as we start to implement this potential model. So in terms of the process, we have been getting feedback in through a sort of a dedicated channel to make sure that we don't miss anything. So any sort of edits or additions can be sort of put in place over the next sort of 2 or 3 weeks. And then all the comments and questions that are received will go into a bit of an appendix in the back of the documents for sort of transparency. And obviously any questions can be answered through that process as well. In terms of support, so as you'd imagine, there is obviously a programme team sort of behind the scenes, making sure we can sort of, keep to the straight and narrow and in line with the OCP process. But there's also wellbeing support, which is fantastic and well received and targeted where necessary to make sure that the staff and teams, going through change are best supported. And it's completely understood, and members will agree that going through any organisational change is hard. It clearly impacts individuals and teams and performance, and therefore that sort of wellbeing support is certainly well received in this process. And as noted, I think at the last session or in some of the engagement events, although we want to make sure we do this safely, properly, and by the book according to the OCP, we don't want to hang around either. We want to make sure that we're not delaying things unnecessarily, because when there's delays, it can cause uncertainty, and therefore that's not good for an organisation that clearly has a lot of ambition and a lot of targets to try and make sure we push forward on.
So finally, Chair, before I finish, in terms of sort of next steps, once the consultation process completes on the 6th of June, all the comments and questions will be, as I say, responded to. Any sort of edits required will be put into place. And then the implementation phase will be in line with the OCP, and there's a lot of concurrent work going on at the moment from a variety of sort of corporate and operational functions to make sure that their various areas and how the governance will work and how the quality and safety system will work is all being sort of put in place behind the scenes as well. And then it's looking like, according to the plan, that the proposed model should be going live throughout the month of July to be able to put that care group structure in place. And the final thing I'll say, a lot of the feedback we've been getting actually is probably more focused at the specialty level and that's sort of the clinical service group level rather than the overarching sort of ILG or care group level. And as the paper makes reference to at the end, and as does the consultation document, the organisation does have an aspiration once the care group model is put into place after the consultation, to try and look at that sort of next level down, the specialty level, to try and make sure that we get that right. But no one's rushing ahead into that, and the organisation clearly wants to use the expertise, knowledge, and experience of those staff in the proposed care groups and in the specialties to try and make sure we get that absolutely right in the future. So, in future updates, we potentially can touch on that as well, as when that becomes known. But that's all I'll say for now. Thank you, Chair. If there are any questions, that'd be great.
Thank you, Richard. Thank you, Paul. Are there any questions or comments for Paul or Richard? No, there's no questions or comments, and to be fair, Richard and Paul, you've taken us through this all the way along as a board anyway about how this has developed, and it's good to hear how it's progressing. Okay, thank you. If I could then go on to the next board item, please, which is 6.5, and it's the CTM 2030 Our Health, Our Future presentation. And I invite Colette Shinohan to share the presentation with members. Thank you.
Thank you. Thank you once again, Chair. I think someone is going to kindly help me click through as I make very quick reference to the slide. So the purpose of the presentation is to update the board generally on the CTM 2030 strategy, but more specifically on an aspect of that strategy relating to how CTM Health Board is positioning itself as an anchor institution in our communities. The Health Foundation defines an anchor institution as large, typically public sector organizations whose long-term sustainability is tied to the well-being of the populations they serve. They get that name because they are unlikely to relocate given their connection to the local population, and they do have a significant influence on the health and well-being of communities. Now, that sounds like CTM Health Board. Slide 2 then reminds us of the visions and the goals that we are pursuing in this strategy, right from creating health to living our values as an organization. If you go on to slide 5, slide 5 goes into more specifics in terms of the kinds of things that an anchor institution does. And that includes promoting environmentally sustainable practices, partnering with other stakeholders, squeezing more social value out of procurement, using estates in ways that facilitate population involvement and well-being, and really championing access to health promoting employment for the local population. And these are arenas that the CTM University Health Board is really active in. Slide 6 then carries this theme of anchors and employment onto the Welsh Government focus on the foundational economy. The terminology of foundational economy refers to that part of the economy that creates and distributes goods and services that are consumed by everyone, regardless of income and status, because they support everyday life. So health and care services, food and housing are key aspects of the foundational economy. And so part of our anchors work in the Health Board fits within this remit on which we're expected to make plans and demonstrate progress through our IMCP. Slide 7 really just burnishes our anchor credentials. Although I must admit that the intended focus there is more about, you know, what we can achieve for our communities given the incredible capacity at our disposal as an anchor institution. And then slide 8 summarizes a few case studies that signal the kind of progress that we have made already in this space across employment, procurement, and the use of our estates. Slide 9 details more specifics of the projects that we are pursuing in this space, while acknowledging how we can strengthen the program through better use of data and metrics, better coordination, and improved links actually to other organizations that are similarly pursuing an anchor institution approach. Slide 10 then sets out the direction of travel for the work, in particular ensuring that it is embedded within our overall development and implementation of the CTM 2030 strategy. So in summary, the board is just asked to note progress on the health board's anchor institution approach and how we intend to align it within an overall CTM 2030 strategy framework. This will ensure that CTM delivers on its potential to be an effective anchor institution that is positively influencing population health outcomes in Clontarf Morgannog. Chair, I'll stop there and take any comments or questions.
Thank you, Kelechi. Are there any comments or questions for Kelechi, please? Yeah, Paul.
Thanks, Emrys. Just wanted to really endorse this update from Kelechi and also to highlight how much of this work is being fed through in the strategy development, and also just to highlight the work that Natasha Weeks is doing in our comms and engagement team, because we are doing some really proactive engagement work now with the voluntary and third sector, talking about many of the topics that Kelechi's just described. And I think it's been, certainly for myself, quite an eye-opener to go out and listen to many of these groups in our communities talking about some of the challenges that our population face. And when you listen and talk to people about what are the things that have an impact on their health, no surprise that a lot of it is not actually about things that we provide. It's about a whole raft of other services and availability of access to various other things in their communities. So there's a real opportunity for us, I think, through this work to really lead the way, I suppose, in how the NHS can work in a different way with voluntary community groups and the wider communities. And also to say that it isn't just about other groups outside our organisation. We had a really interesting session yesterday with our staff talking about some of these topics, because actually 85% of our staff live in our communities. So if we can talk to them about some of these topics and get them engaged in conversations, we had that very conversation yesterday about opportunities for employment, opportunities for leisure, all these sorts of other things. So I really do think, despite a lot of the pressures and challenges at the very sharp end of what we do as a provider of services, that the efforts and energies we're putting into this agenda is of equal, if not more, importance to ensure that we try and stem the tide of some of the real pressures that we've got in our system in future years.
Thank you, Paul. I don't think there's no other further questions or comments. Kelechi, again, thank you for your presentation and noting Paul's comments about how we could be leading the way as well in how we work with our partners and helping to drive this agenda forward. So thank you again.
Thank you, Chair.
If I could go on to the next item, please, 6.6, which is the Regional Acute Oncology Service. And I invite Claire Nelson to present the business case, which we've been asked to approve.
Yes, thank you, Chair. So the regional case was agreed by the South Wales Collaborative Cancer Leadership Group, which is made up of health boards, Public Health Wales and the Wales Cancer Network. It's been to a Nyren, Bevan and Cardiff Vale University Health Board, and it's been approved by them in terms of the early phasing, which is what we're really looking at as well. So just for background, acute oncology is broadly into three groups, which are described in the paper. And it's about the people that present to our sort of A&E departments with cancer when it's suspected, when they have complications from their cancers, and they present if they've got acute complications and comorbidity. So it's patients that we're already seeing in our system, but unfortunately, they're not being seen in a timely and appropriate manner. And the role of acute oncology as a distinct service is to try and improve this. So the paper outlines the strategic reviews that the need for improving the service came from, and also the increase in incidence of cancer, which means that, and clinical practice, which means we're seeing more patients in our emergency units. So this is leading to the failure to meet NICE guidance and national standards, and we also have inequitable provision of acute oncology across health boards. So the cancer unit was asked to have a look at this. So the initial business case put together by the CCLG was looked at by a number of our executives, and it was felt that it didn't meet the needs of our local population completely. So this is why it's a slightly adjusted model, which is here. So the main differences to the regional model are it doesn't include a hot clinic because we already have those clinics in place. It doesn't have education monies, and it allows changes to management. So we have a local manager sort of leading on the service, and we also need to develop digital solutions internally to the organisation, not just regionally. And CTM, as the paper says, being nominated as the lead for the digital elements of the programme. So the paper shows the benefits for our patients in terms of experience and outcomes, because it will ensure continuity and consistency of care. And the first phase of the regional model will increase the clinical nurse specialist provision across all our sites and introduce a formal cancer of unknown primary MDT, which is led by Valindra colleagues. It would also support the navigator role, which is currently funded by Macmillan and due to cease this year because the roles proved to be invaluable in terms of data entry, compliance and signposting. And recurrent funding for acute oncology of this level, 400k, has been identified within our annual plan 22-23. So members are asked to approve the locally adapted acute oncology service model for the Health Board.
Thank you, Claire. Can I invite Patsy in, please?
Thanks, Claire. I think you've just answered one of my, or part of one of my questions. So a couple of things. At paragraph 2.8, it talks about the estimated cost of 785,000. Presumably that's the full cost of all of it, and the 400 that you've just talked about that is included in the financial plan is all that you're asking us to approve today.
Yeah, that's correct. So I think the 785 is the full case with lots of forecasting within that Valindra have put together. So that services, I think it's referred to in the paper as well, for in elements like toxicity service, which haven't been worked up yet. So I know that Anira and Bevan particularly said they weren't supporting those elements of the case either. So they're doing a locally, adapted model like us. So we're only asking for the 400k, which is the initial phases, yes.
Okay, and that is already, Sally, I'm sure will confirm that that's already
that is in, yes.
The paragraph 2.3, it talks about Monday to Friday, and I can see an extension in the hours, but surely the objective or the long-term objective, knowing that it will cost more money, has got to be a 7-day-a-week service, because I would think more people present in an emergency over the weekends than they do Monday to Friday.
So I think this has been assessed by the Cancer Business Unit Nursing Lead for the Health Board, who is looking to extend it, but I think it's what's manageable in the workload. So I think the first bit was assessing that actually it's the evenings that we're getting quite a lot of presentation that we're not covering already. I don't think it was as high on weekends as we were expecting, so I think that's the next stage we'll be looking at, but also knowing just about the feasibility of the staffing model for the weekend. So I think at the moment it was agreed to do the extended hours, and then we'll look at if a weekend is needed.
Thanks, Claire. And Sally, can you just confirm it's fully in the plan? Not that I don't believe Claire, but it is helpful if Sally confirms that.
Yeah, Claire and Mark and I have all worked very carefully together on the plan, so yes, it is within the sum set aside.
Thank you very much.
Okay, I could invite Ian Stuart in first, please.
Thank you, Chair, and thank you, Claire. I'm delighted to see this come to fruition. Actually, this has been a number of years of work, and just a comment really for colleagues, because actually, well, we, notwithstanding, we know that we have some specific sort of data quality challenges within our own health board. This is a real opportunity to do that data quality join up and data definition join up right across our region, and actually not just with our health board colleagues, but also with third sector, and really get a far truer data position and an information position for patients right across the region. So this could be the start of something really quite significant, certainly in the cancer space.
Thank you, Stuart. If I could invite Ian in then, please.
Yeah, thanks, Emerson, and thanks, Claire. This might be a question for Stuart, actually. It's in relation to the what you said, Claire, that there's going to be a localized as well as regional digital solution. I wasn't quite sure why that was the case. I'm always for bigger sort of systems, which rather than making lots of little localized things all the time. But I'm sure there's a very good reason for it. So maybe somebody could explain to me why we're having lots of little localized ones rather than one big regional one.
Great, shall I come in there?
Okay, we can do a joint effort if needed.
Yeah, oh, well, do you want to answer first then, actually?
Well, I think it recognised, Ian, that we'd put all the money into the regional solution. This is before we knew we were hosting it in CTM as well. And it was saying, actually, they're not given any capacity to what we need to do to join up our systems locally. So I think it's thought to be non-recurrent we probably need locally just to make sure our systems link with whatever we need nationally. So that was why. So we didn't want a lovely regional programme that we couldn't implement locally was really the key.
Absolutely perfect. No, I can't really answer that.
Yeah, so thanks for that. Yeah, I thought that was probably the reason.
Yeah, I wouldn't. Sorry, I wouldn't want you to get this idea that we are just got loads of little localized. It's about just being able to enable it across our health board. Yeah.
Okay, brilliant. Thanks.
Okay, in line with what's been required, are we happy to approve the business case? I'm noting on the comments on the sidebar we've got approved, so confirm that we approve the business case. Thank you, Claire, for your presentation. Okay, if I could then go on to the next item, which is the continuous improvement of self-assessment process in response to targeted intervention. I'd like to invite Richard Morgan-Evans in to present the report. Richard.
Diolch, thank you, Chair. So the report is within your packs, and today I'm asking for an approval for the current TI and special measures status. Board members will remember just around about a month ago on the 28th of April, we conducted our latest sort of targeted intervention and special measures self-assessment session, and that obviously boiled down a lot of pre-work done by the relevant senior responsible owners and the teams across the health board. Progress is noted within that paper across the maturity matrices, and in terms of TI, the majority now are in sort of the latter stages of results or early maturity, which is fantastic, and it represents a lot of hard work going in across the health board over the last few months. And this is obviously a process that has evolved over the last 12 months as our maturity has sort of pushed on, which I think is a good thing. And as ever, the self-assessment session was observed by external observers such as Welsh Government, which I think is good for transparency as well. I won't touch on the maternity or neonate statuses, although it's mentioned in the paper, because I think Greg's got an item on that after me, and he'll touch on that sort of development and the good work being done there. The report touches on the fact this will be the last time we report in this way. And we've been working very closely with Welsh Government over the last few weeks to try and get to a stage where we can sort of say, right, what are the conditions for sustainability within targeted intervention, which is, I think, it's been a really good and helpful conversation to have. And these discussions have taken place right up until sort of last week. So it's not reflected in the paper, but at the next board, I can bring back a comprehensive update in terms of the next stages. But in summary, on the Friday the 20th, the last Friday, the executive team met with the Welsh Government team to look at all aspects of this, and people were content with the slightly revised scope of how we move forward. And I think it's about connecting this to the key metrics. And if we are sort of lagging behind in some of the other metrics compared to other health boards, you know, what's the root cause? Why? Is it a structural issue? Is it a leadership or management issue? And I think by sort of joining up and making TI more holistic, I think it'll be more useful to us as an organisation as we move forward in terms of understanding what the outcomes need to be and what good looks like. So we will absolutely bring that back in the future. The next self-assessment session, and as I say, we'll talk through in the next few weeks and months about how that will look, but that will take place in August. The special measures team will update as per they have been doing so far for one last time. And as I say, the targeted intervention side will take a different look and feel to the future updates to make sure that, as I say, we are including more metrics, we are benchmarking ourselves more against other sort of health boards and trusts. So it's a bit more usable and helpful in our endeavour to continue to improve as a health board. So I won't say any more than that, if that's okay, but I suppose this paper is asking for an approval of the current progression within TI and special measures, please, Chair.
Okay, thank you, Richard, for your presentation. I know that we've had a number of presentations just on the progress that's being made, and certainly at the recent presentation with external colleagues as well. Can I just ask the board then, are we prepared to approve the level of target intervention and special measures progression as outlined and endorsed at the Target Intervention and Self-Assessment Board on the 20th of April, please? Okay, confirm with the approvals on the right-hand side that we've got approval in respect of that. Thank you, Richard. Can I then go on to item 7.2, please, which is the Maternity and Neonatal Services Improvement Programme. And I invite Greg Dix and Dom Herford to present the report, which we've been asked and the board's been asked to note. Greg. You're on silence, Greg.
Apologies. Thank you, Chair. Since the last time we met, we've reached 3 significant milestones within our improvement journey of the last 3 years. So we've closed all of the historic serious incidents through our assurance closure panel, and that's been verified by the DU and IMSOP. All of our clinical review cases, so the maternity, morbidity, mortality, stillbirth, and neonatal clinical review have progressed through our clinical cabinet. And just on Tuesday, the Quality and Safety Committee approved the closure of the RCOG RCM improvement plan. We've successfully achieved over 90% of those particular recommendations, and again, that's been verified and validated by IMSOP. The 7 or 8 recommendations that remain in the plan are generally related to the cultural engagement plan, our leadership development. So they will form part of our milestone plan and our roadmap for maternity and neonatal services. So that was a huge pivotal point for us within quality and safety on Tuesday. The Monday, again, was a significant day. We had 2 publications, the first being the 6th IMSOP progress report and the neonatal clinical review thematic report were both published last Monday. The board will recall we had a board briefing 17th or 18th of May, which IMSOP briefed the board on the contents of those reports. That there were no new recommendations in either of those reports. So we will continue to progress with our own improvement plan. We acknowledge that we do need to pick up the pace from a neonatal perspective. Quality and Safety had a very robust, well, several presentations on Tuesday from a maternity perspective, and have asked for the same from a neonatal perspective the next time we meet. We have delivered 5 of the initial 19 deep dive recommendations from a neonatal perspective, and are working through the remaining of these, but we feel we need some more evidence, and IMSOP do equally, in relation to closing off some of the neonatal recommendations. We've equally been challenged from a capacity perspective in relation to staff on the ground supporting the improvements. Very recently, we've gained some further capacity from Welsh Government colleagues, which will really help us with expediting the neonatal part of the plan. From a maturity matrices integrated performance assessment assurance framework perspective, we've landed on maturity, as board members will recall, for both quality of women's experience and safe and effective care, and we're firmly in the results phase for quality and leadership management of the service. We haven't progressed to maturity for that, largely again related to some of the the work around the culture and engagement plan, but we're back on track to deliver that. And just finally, we had a discussion around training within quality and safety on Tuesday. There is an error, a data validation error in some of the metrics in the report, which indicates that our medical colleagues are just hovering over 50% for gap and grow train. And in fact, that's just nearing 90% from the April figures we have. And our director of midwifery assured us that that was the case. So the work continues. Our improvement team will step down this year. We've undertaken a large piece of work in relation to transitioning of our improvements into sustained clinical practice. And again, in Quality and Safety Committee, we agreed, and the Maternity and Neonatal Improvement Board, to step down the programme of work from a quality of women's experience perspective. That's well into the maturity stage now, and in fact, one could argue poking into exemplar. So that programme of work will discontinue, but the improvements will continue within the service. So that's all I wanted to raise on that report. Thank you, Chair.
Thank you, Greg. Jane?
Thank you, Chair, and thank you, Greg. I just want to endorse briefly what Greg has said. We had an extensive discussion, particularly in relation to Maternity Equality and Safety Committee on Tuesday, and I also attended the Maternity and Neonatal Improvement Board on Tuesday afternoon. At both, I encourage the team to give more focus now to neonatal, and with the expectation that the next Quality and Safety Committee meeting, we will have much more detailed information and indication of increased pace, as Greg has said, in relation to the Neonatal Improvement Programme. We were particularly pleased to see the developments in the dashboard and the metrics around the dashboard, with beginnings of external comparators, which can only help the ongoing improvements and ambition and indeed sustainability of the services. So I'm confident that what we've heard today is resilient and accurate. Thank you.
Thank you, Jane. So on two counts here, thank you, Greg, for giving us a comprehensive overview of where things are. Thank you, Jane, as well, just to confirm, both from an assurance perspective and that the actions that are being taken are moved forward, and we've got them on our QPS agenda to note the progress with particular reference to neonates. Okay, there's no further comments in respect to that, so thank you, Greg. And we move on to the next agenda item, which is elective recovery. Can I invite Gethin in to share the presentation with members, please?
Thank you, Chair. I'm very conscious of time, so I will. I won't revisit areas that we've discussed out in the performance report. So if we could go, please, to slide 4. Thank you. So I suppose just wanting to set the scene really for the board to understand how our elective recovery programme governance fits within the organisation and externally. So we have got an approach to the elective recovery which is aligned to the 5 goals of the national programme, and we're focused very much on both the operational delivery but also the clinical pathway redesign and innovation of our services. So what can we do today to address our backlog, but also how can we look at our services, redesign our services so they are fit for the future and can meet the needs of our population. Through that programme board also we are managing assuring the effective allocation of the elective recovery funds that we've received, which were 26.1 million, and that they are delivering the intended benefit to those pathways. And the third bit is really making sure that it properly integrates the restructure of the operating model, as outlined earlier by Richard, to make sure that we're realising the benefit of that and the services. So you can see that we've got a number of projects that sit below the programme board, ranging from very service specific or specialty specific interventions such as orthopaedics, which we're including then the action plan from the GIRFT review, to more thematic pieces of work around theatre utilisation and day case rates, and that is supported then by weekly performance meetings with a programme team supporting that. If you can move on, thank you. And then next one, please. We've talked a lot about the waiting times. You know, we have got a lot of patients, as set out earlier in the performance report, waiting a long time for treatment. So that is a real challenge for us. And if we could then just jump to slide 8, please. And what this outlines is that, but pre-COVID, we had a demand capacity deficit in a number of our specialties. So recovery is a challenge not only because of the volume of patients, but actually pre-COVID in many of our areas, we didn't have the right capacity to meet the demand that we were receiving. So hence why it's so important, as part of doing the longer term piece, that we're redesigning our services and looking at how we can increase the capacity of those, both in terms of capacity to be seen. It is about alternative pathways, which we'll come on to, and different ways of working, including things like day case. So if we can move through, and the next slide, please. So we've got a number of assumptions. Those assumptions are evolving with the ministerial plan, but it is, you know, this is what was the assumptions that were built into our IMTP, which was signed off by board previously. Next slide, please. We are then outsourcing, so we have got patients being outsourced to the Spire Hospital, to the Nuffield Hospital. We're just finalising a contract for additional cataract activity in Bristol, and we're also working with Aneurin Bevan Trust on development plans for Neville Hall Hospital to increase ophthalmic capacity for the whole of South East Wales. Next slide, please. We're also using Medifer, who are another company that are helping us do virtual pathway management. They've taken on a number that when the programme comes to an end with Medifer, they will have taken 2,000 referrals for us, primarily from Prince Charles Hospital, and they are managing those patients in a virtual way, and then, if required, referring them back into the pathways at Prince Charles for ongoing diagnostics and care, but very much part of a different approach around advice and guidance, supporting general practice to look after patients in the community rather than a traditional outpatient appointment. So there's a lot of learning that we're trying to bring into the organisation through that programme. Next slide, please. So in terms of our improvement plan, so we've done a lot of work with Grant Thornton to really understand each of our services and the reprofiling of those improvement trajectories, as I touched on earlier. And there are a number of sort of key interventions that we're taking to support those. The first is that we will go live with phase 1 of our health board wide inpatient orthopaedic unit at the Royal Glam site. So that will see us moving on a temporary basis the inpatient orthopaedic operating from Prince Charles. The reason for doing this is that orthopaedics operating has to be done in an ultra clean environment, both in terms of ward care and theatres. And one of the challenges we've had on both the Princess of Wales site and the Prince Charles site is protecting, ring fencing that orthopaedic ward. So as soon as we breach that ring fence, we have to stop operating. And we can't restart operating until all those patients that weren't ultra clean have been discharged from the facility. So we have, throughout the winter, sustained the ring fence on Ward 15 at the Royal Glamorgan. We can expand the bed numbers of that, and that will be adequate to accommodate that that activity. We then will seek to open up a third orthopaedic theatre quickly after that at the Royal Glamorgan, which will allow the move of inpatient orthopaedics from Princess of Wales Hospital. And this is a move that's really been pushed for by the orthopaedic consultants. It's a recommendation from the GIRFT review, and will allow us to really crack on now and do orthopaedic, a lot of inpatient orthopaedic operating. And as you know, that's a key specialty in terms of our backlog. With the subsequent moves that we can then do on the Prince Charles site, it means that we can reopen the dedicated day case facility again from early July. That has been constrained because it's been used for the green inpatient capacity on the Prince Charles site, and that again will allow us to increase substantially. That's 2 operating theatres worth of dedicated day case activity, and if you think we can probably do 6 to 10 operations per day in each theatre, that's a really big increase in activity that we'll be able to offer. We also are reviewing all our options for increased productivity in outpatient. So there are some outpatient services that haven't moved back to a full clinic template, partly linked to the COVID infection control conditions and also as part of our virtual management. And so we're looking at how we can increase the productivity there with the changes in IPC guidance that have been announced, and how we can make sure that we're using our physical facilities as best we can. We're engaging with GIRFT to come and undertake a review of our ophthalmology service. We recognise ophthalmology is a really challenging specialty for us for a variety of reasons, but equally it's a service that carries a lot of risk if we don't manage long waits effectively. So we're engaging GIRFT to come and help us really to do a diagnostic and to advise on where we can make the biggest improvements to the ophthalmology service as part of that. And we're also increasing the ambulatory capacity in gynecology with the introduction of further day assessment areas at both Prince Charles and Royal Glamorgan, which will help our one-stop clinics for cancer patients, which then frees up more capacity for routine activity. But also later this year, we will open the dedicated breast unit on the Royal Glamorgan site, which again will increase the capacity we've got for treating those patients. Next slide, please. But there's some other developments which I think are also really, really positive. So one of those has been the first contact practitioner model in orthopaedics. So this is around autonomous practice, physiotherapists seeing patients who traditionally would have been referred to orthopaedic outpatients. As you will see, the vast majority of those have been effectively managed with advice and exercise plans, 70%, and only 1% of those have actually been referred on for orthopaedic outpatients. So a really important way of how we can manage our demand in a different way, using our clinical workforce as effectively as we can to make sure that only those patients that truly do need to see an orthopaedic surgeon are referred, and they can be seen far more quickly. So again, it's all about the way in which we operate our services to deliver that care. Next slide, please. We've touched on the 26.1 million, just in terms of the high level breakdown of that. So just shy of 11.5 million is being used for outsourcing. We are hoping to be able to reduce that sum by bringing more of our spend in-house. We can get a better, we can get more activity per pound if we can do it internally. So that is work that we're ongoing, but that clearly is driven by workforce availability. So is a balance. Internal capacity, as you can see, we're already investing about 13.5 million into our base capacity to support. There's a tiny little bit there for program management. There's an awful lot of work that needs to be done with this. And then there's about 2.5 million, which is in support of non-CTM provider costs, such as Velindre, where we're referring more patients as we clear down that backlog. Next slide, please. So there are some key risks which I think board need to be aware of. The first is our ophthalmology capacity, which I think is one of our services with very key constraints. We are looking at all options of bringing more capacity in, but ophthalmologists are not routinely available on the interim market, and so that is a key constraint. Emergency pressures and our MRD position, so our medically ready for discharge position, they again will affect our ability to do inpatient surgery, hence why we're trying to bring as much of that onto the Royal Glamorgan site, where we've already got ring-fenced capacity that we've been able to hold. In the performance report, I touched on the vulnerability of our pathology service. That again is a key risk for us if we're not able to mitigate some of those key concerns, and not just in ophthalmology but in a range of specialties. Securing that additional workforce can often be challenging. We would love to have access to additional funds to support and be able to do more and to run more quickly, and certainly we've made that request to colleagues in the DU and in Welsh Government, but hopefully if we can secure additional funds, we'll be able to do more. And one issue that I do think is really key actually is our ability to move patients between our sites is compounded by the challenge of digital join up between the old Cwmtaf part of the Health Board and Bridgend. So we have got differential weights in different services. And ideally, what we would do is move patients from Bridgend to Cwmtaf or from Cwmtaf into the Bridgend area. Because of the IT, that's an exceptionally difficult thing to do, and creates a huge administrative burden. To move a patient for radiology would require data input onto about 7 different systems in order to move one patient. So in terms of the speed and ease of doing that, and being able to progress that is absolutely an essential part of where we need to go. But I'm happy to take questions there, Chair, on the plan. I know colleagues heard it at Quality and Safety, so apologies for repeating myself so soon in the week.
Thank you, Gethin, and thank you for giving us a clear overview of the challenge. Are there any comments or questions for Gethin in respect to the presentation? I do appreciate that many of you have heard it before, but are there any further comments or questions for Gethin? Can I just ask one question, if I can, Gethin? Is that I know whilst people are waiting, do we do some form of assessment around their quality of life when they're waiting? In the sense of if someone's waiting for 2 years, they might deteriorate significantly and might not even be able to have the operation, for example. You're on mute, sir.
I unmute, doesn't it? There are a couple of interventions that we're taking. So we are continually in contact with patients as best we can, and recognising the volume to check to stay in contact with them, and part of that is clinical validation. So if there are concerns that a patient's condition is deteriorating, then we will bring them forward and move them up as part of that clinical assessment. Equally, we've got services such as the WISE service, which are allowing patients to access access support, both in terms of how to live well with their condition whilst they wait, and that we can signpost them to other services where again they can get some support. So we do try. I think there's probably a lot more we can do to support those patients, and that's part of what we're looking at with those recovery plans. But where we want to focus the main activity of our clinicians is actually to treat the patients, and to move that through. One of the other things, just also for assurance of the board, is that we do harm reviews on patients, so we are reviewing them. We have a lower tolerance for doing harm reviews than nationally mandated, particularly on the cancer pathway, and so that's a really important part of how we can assure ourselves that of the safety of patients on that waiting list. But it is a real challenge.
Thank you very much for getting. I'm sorry, I should have said long waiters as opposed to patients waiting for a couple of years, as I said, so my apologies for that. Okay, there's no further questions. Oh, there is. Stuart would like to come in. Stuart?
Thank you, Chair, and thanks, Gethin. And I think just to give colleagues a short update in terms of the digital join-up, actually. So, and absolutely support everything that Gethin has just articulated. It is a complex programme, as everyone's aware. We are preparing a board development session for you all in June to go through the plan. We actually took a joined up Swansea Bay and CTM plan to our joint management group this week, and it's going to the joint executive group in June, and we'll be sharing that with colleagues in our board development session later in, well, it's right at the end of June, actually. So in terms of it is complex, it's multifaceted in terms of the number of systems involved. We've got a staged rollout. A number of things can be done within this year. The things which are more core and fundamental around the Welsh Patient Administration system, which will take longer. And that is at the heart of some of the challenges that Gethin articulated. But in reality, it's going to be a 2-year programme of work to actually fully move across. There is additional funding, it sounds like a broken record actually, but there's additional funding that will be required for some of this. And as colleagues have rightly outlined, there's also a dependency on colleagues within Swansea Bay to prioritise some of this work as well. So it's a really joined up multi-health board approach, but we do have a plan. And as I say, we'll be bringing that to you in June.
Thank you very much, Stuart. Just thank you again, Gethin, for giving us keen overview of the challenge we've got and the systems and processes we've put in place to manage this. Can I go on to just coming to the end of the meeting here now? Item 8. Nothing's been raised with me prior to the meeting on any other business, so there's nothing further to add there. In respect of how we've done in this meeting, which is part of our governance development, if anyone could give me comments conscious of time outside the meeting, that would be better to manage it that way, so conscious of time. And then the date of the time of the next meeting is to be, the next formal public meeting will be held on Thursday, the 28th of July, 2022 at 10 o'clock. And in closing the meeting, rydw i'n dod ar cyfarfod o Bwrdd Iechyd I Ben a Hoffwn I ddiolch I bawb sydd wedi ymuno a ni a gwylio cyfarfod. I now bring the board meeting to a close. I would like to extend thanks to all who have joined and observed the meeting today. Thank you.